Test. Test, 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 test. Keep going.
Good
morning. It's 10:05. We'll call the meeting, this special meeting of the Joint Board of Managers and Finance Planning Investment Committee to order. Thank you all for being here. I think we just need to attach finance in front of every meeting. We can get a full house and get everybody here, and that'll be good. I'd like to start the meeting off this morning with Angela McDonald with an opening prayer, and we'll then recite the Pledge of Allegiance.
Good morning. Let us pray. Gracious God, as always, we thank you for the opportunity to serve our JPS community. In our hearts, we plan our course, but we pray that you order our steps. Strengthen us as we make decisions today. Guide us so that this meeting will be productive and effective. And fill us with your wisdom and humility so that we continue to lead as a reflection of your love and fairness. Amen.
Thank you. Please join me for the pledge. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, are there any citizens wishing to address the board? There are none. Finally, I'll move to approval of the minutes. This is the meeting minutes from our August 22nd board meeting. I'm sorry. Oh, we've already approved them. Okay, we did that last time we met. Sorry. There's been a lot of meetings, y'all. I'll apologize. Thank you all.
Mr. Chair, when will we approve the minutes of the early September board meeting? When will that be up for approval?
That will be at the next board meeting in October. I don't have much by way of chair remarks other than to say thank you all for being here today. I do want to let the board know and everyone know that Laura Lehman had a tour. Laura is a Democratic candidate for Precinct 3 Commissioner. She was here last Friday and had a great tour, and I appreciate staff for showing us around again. I'm always fascinated. I've seen the tour 10, 15 times. I always learn something new every time. But what I do notice in that tour is the enthusiasm of the staff and how proud they are to show off the various departments, what they do, and then also see the excitement when you get out on the third floor of the main building and really begin to see not just the dirt flying, but now the concrete rising out of the ground as the master facility plan is really coming together. So
I feel bad.
Well, we'll get Ralph Emerson's medical home on the next time. Anyway, that's really all that's happened really since the last meeting, I guess, and the other stuff we'll talk about here in a bit. But with that, I have no further remarks. You have none, Dr. Duncan. With that, we'll move to a report from the medical executive staff. And there's no report. Well, we're just moving right on. There's no committee reports in action.
This might be our greatest meeting.
Cue the music.
Let's get loud.
Let's get loud. Okay, then we'll go now to talk about the fiscal year 25 budget, which is what I guess most people came to. So it came as a surprise to many, if not all of us, when the Commissioners Court unexpectedly approved a tax rate of 0.1825 for the hospital district last Tuesday. As you are aware, this board unanimously passed our fiscal year 25 budget with the court's proposed maximum rate of 0.1875. In addition, the Commissioners Court last Tuesday approved our fiscal year 25 comprehensive budget without any changes. From my perspective, it's worth noting that to the best of my knowledge, neither the board nor any members of the staff were aware of the possibility of, or I guess we were aware of the possibility of a lower rate, but we didn't expect that to happen. The sudden approval of the lower tax rate caught us off guard, And in response, I immediately tasked Dr. Duncan and her team with assessing the impact of the approximate $14 million decrease in tax revenue in our approved budget. Their proactive approach was evident as they had already begun their analysis even before leaving the courthouse last Tuesday. As you all know, our staff dedicates several months and countless hours to meticulously plan a budget that addresses the needs of our community while aligning our board's 3 strategic priorities of workforce, access, and financial sustainability. Any alteration to that budget could have far-reaching implications. At this juncture, it would be unfair for our team to it would be unfair of this board to request our team revise the current budget. The intricate causal relationship with each line item is a painstaking process, and any alteration we make could potentially compromise patient care or harm our employees by depriving them of earned raises or merit pay increases. Therefore, the most prudent course of action at this point is to remove the $14 million from our bottom line. This decision will significantly alter our margin for fiscal year 2025, but it should keep us within the limits of our bond covenants and the good graces of the rating agencies, which at this point in our master facility plan is really, really important. With no formal vote required, we felt that it was important to share the updated income statement that reflects the approved tax rate as inserted into our previously approved fiscal year 25 budget. This is to ensure that the board members are fully informed of the updated information. It is important to note again that this does not require any reapproval, since at this time I don't anticipate we will be making any changes to the budgetary items as previously presented to this board. I understand at this point some members may want to share some comments on the process, and I'll open the floor to that, but first I'd like to share mine. In this room and in most subsections of our county, we talk about big numbers, and we look at financial statements that are abbreviated but stated in the thousands. Because of this, we might sometimes get numb to the weight of those numbers. We talk about billions and we forget about millions. But the millions are just as important as the billions. The most common thing I've heard in regards to the budget and a lower rate than what we proposed is that it's only $14 million. And that's true. It is only $14 million. But if you zoom out a little bit and realize that in the past 3 budgets, taking into consideration homestead exemptions and rate decreases, that amount is over $60 million. Now, $60 million back to the taxpayers is a victory. It's a victory to every one of us, and that's great. However, these same taxpayers instructed this board in this county with their vote of overwhelming support to build new facilities and expand healthcare access in Tarrant County. We did this with a promise of not raising taxes, and they did this with a promise of giving us $800 million to do it. This is the promise we made, and I understand that the politics of the situation might be different, but we don't get to change the promise, and we don't want to change the pledge. We still intend to build this master facility plan in cash, every penny of it, over the $800 million without raising taxes. But $60 million plus over 3 years pays for 1 medical home plus some. And in 6 years, having left the rate the same, we could have built the 3 future planned medical homes right there. The other thing I have heard is JPS makes too much money. And I'm not sure that's true. Under the direction of this board, with buy-in from Dr. Duncan and her excellent team, JPS has become very adept at saving money. For at least 8 years, this board has insisted that every dollar of extra revenue is deposited yearly into our future fund. Dr. Duncan's implementation of Fit for Growth allows this hospital to focus on its core mission while saving millions of dollars. Every department is finding ways to do their job better and more cost effectively because they know how important the master facility plan is to the future of healthcare in Tarrant County. There is no doubt also that congressional inaction to reduce federal reimbursement significantly helps our bottom line. And there is no doubt that a significant amount of our future fund are those dollars. So no, we are not making too much money. The entire JPS team is an incredible steward of taxpayer dollars. So that brings me to what we can do as a board. We need to ensure that we give our commissioners every bit of information regarding the budget and performance, and we give it to them regularly, and we give it to them often. We will begin, probably starting next month, making a note at every finance meeting and specifically calling out the future fund and what it means to meet the bond requirements. The bonding ratings companies tell us what our margin needs to be, what our cash on hand needs to be, and additionally, we have to address the deficit in the master facility plan. It has to be paid in cash, and right now, that's somewhere close to $90 million a year. We have to break the cycle, this board has to break the cycle of only sharing a message of what JPS can give up. And we have to get to a point in our relationships with our commissioners and the way that they feel about this hospital system to where they ask us what we need. The Star-Telegram had an article entitled, "Commissioners Vote to Cut JPS Tax Rate. Here's How Much You Will Save." I keep reflecting on that headline and wonder why it couldn't be written, "Commissioners Vote to Cut the JPS Tax Rate. Here's how much it will cost you." I can tell you the cost, and it's not money. It's access, it's patient care, it's quality, it's reputation, it's academic partnerships, and a degradation of a fantastic team. It's everything JPS was. This board has to do a better job with our commissioners to make sure that they know where JPS sits, where JPS is going in the future. We will follow their lead, but we need to make sure that they have all the information. This is the consolidated income statement with showing the reduction from the 278 million to the 138 million, reflecting the rate cut. It brings our projected operating margin from a 9.2 in fiscal year, to our operating margin to a 2.1, and that is right at the mark of where the bonding agencies say we need to be. With that, I'll open up to any questions, or we can move on with the agenda item.
I would agree with your presentation wholeheartedly. My question is, even though we have meetings with our commissioners, I feel that the board has to be in sync, that we don't go to our commissioners and continue to say, we got this revenue, we can keep reducing the tax rate. We've got to be on one accord that we're committed to fulfilling the master facilities plan as we promised the voters. So my question is that are we sending mixed messages to the commissioner?
Reverend, I appreciate that. I agree. I haven't spoken to every member here, but I think this board is pretty much on the straight and narrow as it pertains to the future fund and the master facilities plan. I think everybody realizes the importance. So I think that we are on the same page there. I don't know that there's mixed messages being sent from this board. My point is that we've got to make sure that we're saying it continually and repeatedly to make sure it's clear.
Okay. I'm not so sure, because some months ago, I heard from some board members here that said we need to cut the tax rate. Not looking at of being sensitive to the master facilities plan. And my thing is, for me, comfortability is I need to hear that we all on one accord to fulfill that plan, and at least talk to our commissioners not to be so insensitive to the needs of our community and the citizens to fulfill that master facility plan.
Yeah, I agree, and I think that this board, I know we had one member absent or not present at the vote. This board was unanimous on the budget, and we were taken by surprise on the rate.
Okay.
Yeah, can you take a few questions?
I guess I'm not altogether prepared for an interrogation, but I'll do my best.
I mean, this budget that's in front of us right now has the exact same spending as the budget that we approved before.
Correct.
Right? The only thing that is different is the amount of income or profit that we will make, correct?
Correct.
You said in your statement at the beginning, and I hope I wrote it down correctly, that you're concerned about access and patient care, quality of care, and the effect on the team. Can you tell us how?
Sure. If it's going to be very difficult for this hospital system to continue to operate going below no new net revenue and keeping up with the master facilities plan process. At some point, it may not be this year, it may not be next year, and it may not be in 27, but at some point, when the money in the future fund is spent down, is drawn down because we're building, patient care and access is going to be affected.
So the concerns that you're raising are future concerns, not right now concerns.
Not today concerns, but they could be concerns next year easily and the year after, for sure.
So, but this budget, though, we shouldn't have those concerns as it relates to this year.
Right.
This is the same that we're planned to spend before.
Right. And what we're doing is we're going to be putting less into the future fund next year to continue. It makes that what was $83 million at the budget presentation closer to 90 that we need to put every year for the next 5 years to make sure that we can fund the commitment.
I certainly understand that as a concept, that
Yeah.
the more money we have, the more money we'll save. But I also am wondering, is there any other organ or entity of the county government that turns a profit?
I don't know.
Is there any school district that turns a profit?
Certainly not the one in which I live.
Right. And I mean, they all operate under the same kind of bonding system and receipt of public funds that we do, is my understanding. Is that correct?
Sure. We also,
I don't
well,
think
no,
so.
no, it is
I don't
different.
know.
Yeah, we've got a revenue source. You got to remember.
We have even more revenue sources than they do.
Right, but remember,
Right.
only about 30% of the revenue that the county pays is the revenue that is only 30% of our budget.
Yeah, so I guess that's
There's
a fair
outside
point.
sources.
We're able to obtain even more money than they can because we have other payer sources.
Sure, up
for
until Congress decides to act and pulls, hundreds of $millions away.
Yeah, well, a hypothetical from the future, sure. I mean, I agree, and this is always going to be a political discussion
Sure.
Among us and with connection to our colleagues and each other and our commissioners especially. I just think that we should be incredibly proud that we continue to turn the profit that we do, and I think that we need to be realistic with the rate along the way with that. But I know it's the reflection of a lot of hard work, and I sometimes feel like we're the kids who ask mom and dad what we can do for the allowance, and that's the reality. That's the political reality. And so I think you're right. We can communicate with them. I think we did communicate with them. This was a 4-1 vote at the Commissioners Court. And so they saw what they needed to see, and I think they did what they did because they trust us and they trust the staff to do the fantastic job that they've done most recently with it. So I think we're in a good spot, and I'm glad that we're able to honor what the taxpayers did when they elected folks who ran on this exact issue, and that's been since the bond. When they ran on this issue of reduction of the rate and a reduction of the taxes that folks pay, this is going to be a net positive for the county.
I agree with you that the effect this year is, yeah, I mean, we just took some profit off, and that's fine. The effect is longer term, and making, if we had the $500 million deficit sitting in the bank, you know, ready to go, and the future fund was, or in the master facility plan was fully funded, yeah, I agree. But this outstanding margin is a result of incredibly hard work that I think, honestly, staff feels like the more money we save, the more money they're punished. They are looking at, they have bought into this master facility plan and this goal and moving forward. And it's every penny we save, everything we're doing for the future of this health system is taken away for the instant gratification of a larger tax cut.
But yet we're paying for everything that they requested.
Yeah, you're absolutely right.
Yeah.
Roger, can I make a comment?
Trent,
This is a policy perspective, right? The decision to not change the budget is a policy decision. And our staff has made the recommendation that we not change the operating expenditures relative to the expected revenues. That's a policy decision. Staff could have come back and said, we recommend that we continue to fund the future fund at the same level we had contemplated it so that we have no worries about the future fund being adequate to cover the cost of facilities. And as a result, we're going to reduce the budget by $14 million. They could have said that.
right.
Right? So I think it may be too convenient to just take the position that this has no impact.
Yeah.
Because the staff recommendation was that we continue with the budget. And I expect everybody on this board is going to go along with that recommendation. But let's not forget the fact that's a policy decision. Because the bottom line is, as we move forward to the facilities plan, I would love to come back and visit the board in 5 years. And let's look and let's see. Because the effort that has been made to save money, the effort that has been made to put money away has consistently resulted in the perception that we have too much money, therefore we should take it away.
Right.
That's not conducive or motivating to continue saving money.
Right.
As a matter of fact, it's exactly the opposite. And from a governmental policy perspective, most governmental entities take every single dime they can get, they spend it all because they're worried if they don't spend it all, they're not going to get it next year.
Right.
I've been in this business a long time. It's the same thing here.
Yeah.
So let's not lose the fact that this is a policy decision that the staff has recommended, and I expect we will all go along with it. But let's not be deluded and conclude that everything is just like it was going to be.
Correct.
Because like you said, Roger, 5 years from now, it's probably not be just like it's going to be.
Right.
I don't want us to get into a situation where we have to either tell the taxpayers, we're going to have to raise the taxes back to what they were 4 years ago in order to finish these facilities, or not build the facilities. That'll be a policy decision too. And I'll respect that. And I certainly respect this board's decision, whatever the staff's recommendation is today. I just don't want to leave off of the record, the conclusion that JPS has done a pretty darn good job putting money away for a rainy day. And we've consistently been told that, well, you probably shouldn't have done that.
Yeah. Thank you, Trent. Blake?
First, Roger, I think we should vote on this new budget today. A budget is not just expense, it's also revenue. We have a projected $13, $14 million decrease in revenue. I think that needs an official statement from this board. I'll let you comment on that, and then I have a couple of comments.
All right. Devin? It's really not required because the budget itself did not change. We didn't change FTEs, we didn't change patient days, we didn't change any line item in the budget, and the Commissioners Court has already approved it. So Daphne will have to explain to you the ins and outs of that process.
Right, we did discuss the implications of updating the anticipated tax revenue to match what the court actually approved. And I think it is our position that we're not actually changing the requests for the expenditures that would go into the fiscal year 25 budget that the board has already approved. So we would just update to reflect the anticipated tax revenue, and the board would receive and file that to the extent that we're not being directed to to change any of those requested expenditures. And I will just mention also that we are less than a week out from the end of the fiscal year, so it would be really a challenging thing if we're going to take the position that we have to approve a new budget just to reflect that tax revenue.
Well, I think, Trent, if I heard you right, this is a policy decision not to change the line items. So while the only thing on the budget, well, the budget is different, we have a line item that has changed, that's ad valorem tax revenue. We're making today, either silently or by a vote, a decision not to change any of the expense items on the budget, and I think that needs a statement in the form of a motion and a second and approval by this board for that change. I don't think we should just let it slip by and not have any action taken.
I think you could reaffirm your prior approval of the budget as updated to reflect the new tax revenue.
I mean, is that semantics?
It is. But if you want it reflected on the record, what we were looking for is if there's opposition to leaving the budget the same, then we would have had a negative motion, right, to go back and change it. But if the board does not give that motion, then we would have accepted that it's already been approved.
Well, I mean, to Blake's point, if we could certainly take a vote today to authorize the amended budget, because the fact is, we did change the revenue.
So we wouldn't be presenting a new budget.
We didn't change it.
On Tuesday.
Or it was, the one that's presented, I should say.
No,
Let me ask you
we
this,
did not
from
change
a
it.
finance standpoint, right? Those are, we can consider that revenue or whatever that is to offset. It's the same thing as if the government, CMS, decided that we're going to change the percentage of what you can claim on the cost report. We don't go back and change our budget. We just have to adjust to it because we know the bottom line. The only thing different is that, is it fair for the employee to be measured by the adjustment that was made out of their control? And that's more like a policy and how we run the HR department for performance, for retention and all that stuff. But it's the same thing. If somebody declare cost report, CMS said, I'm going to take one point out before you start the year. Do we go back and change that, or we make an adjustment internally to do that? So I treat that as the same. I'm not sure if it's material enough to go back and reaffirm or do any of that stuff, because I don't do that in normal business.
Well, the difference is, DT, is that this is known before the year begins. This isn't a mid-year change. We have a dance with the Commissioners Court every year. Sometimes we step on each other's toes, but we have a dance between the tax rate and the budget. The tax rate changed at the last Commissioners Court meeting. We know that, and so now we need a statement of affirmation that we approve this budget that's in front of us, because the budget we approved, and I brought a copy of it in case anybody wants to have it handy, the budget that we approved in August is different. The numbers are different. And so, yes, the expense items are the same, but I think just for good governance, there should be some action taken by this board to say, we approve this new presentation, even though only one item changed, which is ad valorem tax.
I mean, for me, like every quarter, you have to readjust everything. Do we need to reconvene and reconfirm of everything, right?
No, again, this is the beginning, this is before the budget year starts. There are a lot of...
Blake, if you'd like to make a motion to affirm the budget as presented,
we can say, fine.
We could do that.
Okay. And then a couple of comments. We are not making money. And this is why, when I joined this board, I asked that we move ad valorem tax to the bottom of the financial statement. The number I look at is operating income or loss. The year that's about to end, we're projecting a $351 million loss. The year that we're looking ahead to, fiscal year 25, we're predicting a $451 million loss. Without the property taxes, we'd have a real problem. It's the property taxes that keep us above zero. And had the court released 18.25% in August instead of September, I don't think we would be having the indigestion we're having today. I was expecting that rate or something close to it, and was surprised when I heard the 18.75% number. And so they ended up getting to where I thought we would be. And as I've said early in my tenure here on this board, my long-term goal is a tax rate of 0, that we are running our operations well, not barely squeaking by, but running them well on our own revenue sources from providing healthcare services. And we're a long way from 0 at 18.25, but I think it's the sequence of what happened in the last few weeks that's caused some distress, and not where we are at 18.25. I agree with you that we should look at the millions, that 14 million is a big number. We're about to hear a presentation on our construction budget. If 14 million bothers you, then you should be bothered 40 times more by the fact that we are $600 million over our original construction budget. And I haven't heard an explanation for that adds up to 600 million. I want to hopefully get some information from our presentation later in the meeting today. That bothers me a lot. Somehow, if we're going to continue to build all these buildings, we have to come up with that 600 million in addition to the 1.5 billion that was originally budgeted. And I think what would be helpful to keep the court and this board in alignment with each other is a quarterly presentation, and this would be some work by Rory and his team, showing a 10-year cash flow projection. And at the end of the 10 years, theoretically, our cash set aside for construction, or maybe it's 8 years or 7 years, but till the end of the construction program, at the end of that time, our cash should be 0. We will spend our last dollar on our last bill. And then there's no extra cash for construction. And then if we have that, and it's going to have to be adjusted periodically, that's why I'm saying quarterly, and we present it to our commissioners and the judge, they can question that, but then everybody's on the same page that all this cash eventually will go away when we paid our last bill. I think that would help a lot, and it should be a one-page presentation, nothing 20 pages long, and we should review it as a board and then give it to our commissioners on a quarterly basis. And that's all my comments.
Blake, a question. The recommendation that you're making is not that we get to 0. The recommendation, I think, would be to be consistent with board policy, anything over the stated policy reserve of the board in terms of unencumbered fund balance, right?
Yes, Trent, I'm talking about cash for construction.
Yes.
I'm not talking about reserves for running the hospital. This theoretical future fund to pay off the construction bills, that when you pay your last bill, it's like when your kids get out of college, your college fund should be 0. You don't owe anything, they're done. When we're done with construction project, the cash set aside for construction, we paid off the bonds, we paid off the bills, and we have 0 left. But we still have money in reserves for normal hospital operations.
Okay. Just making sure I understand.
Yes, sir.
I would not be in favor of eliminating the concept of a future fund, because a future fund is a policy decision of the board that says we always need to be setting aside capital reserves. JPS went for about 40 years without taking care of capital maintenance obligations. And I mean, not taking care of them is an understatement.
Yeah.
And so part of, I think, the board's philosophy over the past decade has been, look, let's recognize that if we become a 0 spend organization versus a 0 revenue, in other words, there is no margin, there is no profit, we're using exactly what we get and that's all we're using, I worry that we go back to that illumination, if you will, that we have significant capital obligations, and our capital obligations, quite frankly, are about to jump dramatically. I mean, our depreciation numbers are about to change dramatically. So I completely agree with what you're saying, Blake. I just want to make sure that we keep as a priority the policy of continuing to support these capital maintenance reserves that ultimately are going to replace equipment and facilities, that if we don't do it, they're not going to get replaced. We let the basement, go for a decade, 2 decades. And honestly, to the point that it was dangerous. And I just don't want to ever give the staff the notion that it's okay that we're not putting that money away to pay for that stuff.
I think that's a great, I'm sorry. I also think as you're looking at
what we should have, then we need to have a fund for all the patients that we don't know that are going to show up, because we continue to grow our patient base. And we have to have dollars, so when we talk about service and access there. So when people start saying, let's just do away with that, that also impacts what we can do too. And since we cannot shut our doors when we get this many patients, it has to have some flexibility so we can continue to take care of patients. So I am against not having a future. I also know that, I know, Blake, you keep saying we want to go to zero. Then I think part of your plan should be that we are not going to be a hospital district. Because that means we would be a zero.
We need to start the
The for-profit, yeah.
Well, let's focus at the issue at hand and the current budget, because we're not going to do anything without getting that out of the way. Tim, did you have anything? Go ahead. Leonard?
I do a couple things. One, I think words matter. And so I'd maybe like your perspective, Roger, Karen, when we say, as we look at the budget, here's where we're saving. And to me, that can be interpreted as cost-cutting and not providing services that we're responsible for and people are depending on. Is a better word, we're finding ways to be more efficient. And I'm just kind of curious as to, because it's somewhat of a philosophy and it's somewhat of a messaging communication of, your perspective on that.
Yeah. Karen?
But no, I hear what you're saying. I mean, I think by virtue of who we are, we do not turn away patients. We do not decide who it is that we're going to see. Our physicians and our teams do not know when that patient walks in whether they're a JPS connection that is supported by the taxpayer money or whether it's a Cigna patient who has walked into the door. So we are always, and we talk about this, I mean, one of our priorities is access, is increasing access. To Dorothy's point, Tarrant County continues to grow. Every hospital in this system is pretty much busting at the seams because of the growth that's going on in Tarrant County. 40% of what we see are those who do not have a dollar attached to them. That's very different than THR, Baylor, Medical City, HCA. That's very, very different. There's only so much we can do as far as saving without intentionally deciding we're going to see less of the JPS connection or the uninsured population. So I hope that answers, but I do hear what you're saying. And I would say that our fit for growth, which we've brought a couple times, we don't get into the detail, is all about developing those efficiencies. Using technology, the board has approved a huge amount of dollars that we start to optimize our technology so that we are quicker at what we do, we're better at what are doing. We do know that our workforce is the largest part, and we know labor cost, benefits on that. I mean, 60-some percent, almost close to 70% of our budget are employees, and so is labor. And physicians are high cost. I mean, they are highly reimbursed, and nurses are too. So healthcare, just by virtue of the skill set and the experience that you need, drives a lot of those labor costs. We've got to be competitive in the market for those physicians in order to get the best physicians and keep our quality up high. I would say that we are always working on, we have a great quality team, we have great performance improvement excellence team that's always looking for ways in which we can move more patients through the OR or through our clinics in a way in which we can get that next patient there. So I hope that answers your question.
Yeah.
And Leonard, I think everything is not just about cuts, but is efficiency. I mean, you think about the throughput and being able to see all the patients that we see through the emergency department. Well, being able to see people at the emergency department is making sure that we're getting people checked out of the other floors of this hospital so that there's room for people to go. So I think efficiency is the main driver of cost savings. Because I know this team, and cutting patient care is the absolute last thing ever possible, that and quality, period.
Yeah, yeah. And I think, again, it's important messaging, how we present that. My second question, Roger, from what you mentioned as kind of the three tenets of, what JPS represents and the role we play in the community. So, and it's somewhat related to Blake's comment or suggestion, is I'd like to better understand the context of our financial situation and commitments as it relates to the immediate budget and what's forecasted in terms of the master plan and so forth. What is communicated to the commissioners? What scenarios are they presented from a modeling standpoint, from a financial commitment standpoint, to understand the consequences of a near-term decision as it relates to the long-term decisions? What information are they provided?
Well, they certainly see this information in the budget. They certainly see the cost increases that we've had with inflationary pressures on the bond project. And that's part of my comment is we need to do better. I, as board chair, need to make sure that we are giving you guys all the information so that they can see more of that long-term outlook, so that they can see some of that modeling, because I don't think that we've been very good at giving them all of that. We had the bond steering committee.
And there is updates to the court.
And that's,
And it's longer than
yeah.
through that bond, through our steering committee, and here, because you look at a budget for a year, but a capital program is over 10 years. So we've tried to show those expenditures of that way. I think the board and the staff have done a real good job of looking at dollars that we are getting from other resources and saying, let me say it another way. Since we did that bond program, it was just $800 million, we knew when they approved it that we were going to need additional money. The court at that point kept the effective rate, and we were able to start putting money back to help with that future deal. Staff had come and looked at the operations and said, let's see if we can streamline so that we would have those extra dollars, because we knew 800 million was not going to do a third of that, what we were committed to do. So we set up that bond steering committee with the judge and another county commissioner and said, okay, and their staff, let's look at how we can project how we are going to be able to fund this. And they were aware of that. We still go through that. And I know we sit here at this board and looked at a budget for a year, but that capital expenditure, they show it over 10 years showing where we're going to be. And I think that to me, that's a great way to look at it, because if we don't do something now and put money back, when we start bringing up we won't be able to. It's no way that you can say we can't take some of our dollars and start looking toward the future. And so now that we have a different court mindset, my goal has not changed. We would still look at operations, making sure that we are efficient. We are looking at how to increase revenue. Those dollars would continue to be there. And I don't think that, I do think that we can do it. I'm not sure we can do it if we go to $0. We can't do it. So.
Dorothy, on the bond steering committee, who are those individuals?
It's myself, Dorothy, Trent, DT, and Tim.
But I thought some commissioners were on the...
Commissioner Brooks and The administrators are there. And Chandler.
Chandler's there. We've had from time to time, we've had other commissioner staff
Yeah.
attend as well.
That's, okay.
Andy Wynn has been also.
Yeah, Andy's been in some of the meetings.
Okay, my question is, so that the court has been involved in that bond steering committee
Oh, yeah.
projection?
What I can do a better job of is making sure that information from the bond steering committee, once it's been to the committee and it's been presented back here, that there's a takeaway page that those conversations can further make sure that they're disseminated through the court.
Blake, is this what you're talking, what you're wanting or requesting?
No, well, it's all related, but back to the cash flow statement. I'm not, on this cash flow statement, the purpose of the cash flow statement is to show us as a board and the court that the money we've set aside that's on our balance sheet is not excessive and that it will equal zero for the master facility plan. I'm not talking about future projects. I'm not talking about running the hospital, but carving out this master facility plan, which is now $2.1 billion, it will show at the end of that period of time, whether it's 7 or 8 years, that we have spent all the money, we've paid back the bonds, the buildings are all open and operating. Now, we may have other cash for other projects outside of the master facility plan. And of course, you have to have cash, any entity, for emergencies. I'm not talking about that, but that way we're all on the same page. And we could argue over the details of that statement, of course, but you want it to be as accurate as possible, and it will have to be updated and revised because there'll be constant changes. But it will show everyone that at the end of the project, all of the cash that we have accrued is gone. And we paid our bills, we paid our bonds, and we have these beautiful facilities. And that's separate from other cash to run the hospital or for even, of course, to run any entity, you've got to think of CapEx and you've got to plan for that. You either pay as you go or you set aside money, you're going to borrow money. That's separate. I'm talking solely about the master facility plan, the $2.1 billion plan. That cash flow statement, updated quarterly, presented to our commissioners and the judge, keeps everybody on the same page. And again, you can argue over the details of that page, but at least we're on the same page.
Okay, any other? Oh, sorry, Amanda.
No, you're fine, you're fine. I think sometimes we have short memories. What is it, 2.5 years ago, we had a global pandemic, coming out of it. Majority of us were on this board during that particular time and looked at how the staff really dealt well with that. I think that sometimes when we talk about these big dollars, these big monies, these opportunities, and when we're talking about $14 million off the budget, what does that look like per taxpayer? We're looking at what, $35 per taxpayer cut?
I think it's
Like
average taxpayer was like $55.
Like $55. So $55 two pizza meals. I'm all like two. If you have a large family, that's a whole pizza deal. I paid $42 for 2 people the other day, right? So when we're looking at these things, I know Tarrant County, I know our citizens, and thinking in those terms also, and looking and taking some of the politics out of this, because a lot of this is just is political, and understanding that the main mission of JPS is to make sure that we are here for anybody who needs those supports. That also includes our level 1 trauma center for our frontline staff. We're the hospital of choice, the first one for every fire department, police officer within, 9 counties? And so I think that we have to think about those things when we're talking about these money and these conversations and these long-term items that are happening for our future as well. And also, if we go to zero-based budget, if another pandemic comes up, because COVID's on the rise again. I don't know how many people I know that have COVID right now. We know RSV, there's going to be some other kind of mutant strain of whatever. How are we going to respond to those things when we're sometimes tied up? So I think that the citizens, knowing them, knowing the caring, charitable families that they are, at $52, it was it's just unbelievable that we had to have that additional cut at that particular time for this particular hospital. Knowing also that we also support other hospitals as well too, and there's a great community of conversation and talking through. JPS is a drop in the bucket to the amount of care that is needed in this county. A drop in the bucket. But We do it with very, very amazing staff, with amazing doctors, with amazing janitorial staff, and bedside workers that are always here. I think some of this we forget when we talk about these numbers, that we're dealing in people, and that people matter here. That my sister who comes in here, who comes into the emergency room, doesn't matter. They don't know who she is half the time. They're treated so well, as with every other patient, that I think our citizens at $52, a difference that we're talking about, would be willing to step up for that. Yeah. Thanks for the breakdown. So that's my stance of where we're looking at. I think we can look at, yes, longer term projections, agreed. We do need to see some of those things. I would.
And we have to support 9 counties. It sounds federal law force us to take care of them when they walk into the emergency room. You can't turn anybody away unless you want to face jail time. So that's the problem that we have to deal with. We don't label a patient because it's unfair put that pressure on our clinical team to say, hey, if they are JPS connection, they don't have insurance, treat them differently, treat the other one better. We don't have that. And to understand, we can talk into our face turn blue. Hospital financing is very, very complex when you deal with cost report and all sort of things. We may see the room is cool right now. I'm sitting here with Trent, and we understand hospital finance very well. And I'm sweating along with Rory, and everybody says, well, it's cool here. You don't need the AC turned on. But those are some of the complex ones. And I think the big difference is that, yes, we need better communication with the court, because the last court understood hospital financing very, very well. And they understand that the money we set aside, also the interest that we earn and all that stuff, add on to our bottom line also as well. When that thing depletes, we no longer can count on that hundreds of millions of dollars sitting there that making money for us to pay for other operational stuff or whatever that is. So unless we find a better way of educating the court about hospital financing, it's almost like and cost report and all that stuff. I think it's a dead end. It's going to go back to political, and we did not point here to do political stuff. We are point here to look at the future for the next 30 years as we plan for the hospital. So I'm just sweating here. Every tax rate that they cut, I said, wow, that's going to have a lot more impact. But they don't see us as economic drive for the county either. We are not just taking care of the poor. Yes, we're a safety net for that, but we also a safety net for the expansion of other large industrial here in the county to take care of that. If something, God forbid, something blow up at Lockheed or Bell Helicopter, where they're going to take the employee here. So as long as we can provide that quality of care and they can take their employee here for emergency stuff, the expansion pay for the property tax and they live in the area. That creates a lot more long-term for the county also as well. Those are the economic boom that we don't take it for granted. We are the large employer in the county also as well. And education too, and all that stuff. So, but the sad part is that we can't deny any care. I wish we can, but the charter called for us to take care for public safety.
Well, I thank all of you for your comments, and I thank all of you for the diligence, certainly in the budget process. We were thrown a little bit of a curveball. It's nothing that we can't get over. It's something, and we will. So we have a choice. I can accept a motion to affirm the budget as revised, as the ad valorem is revised, or we can simply go off the approval that we had from 2 weeks ago and have the budget filed with the affirmation from this board that nothing intrinsically inside the budget outside of the ad valorem revenue changed.
Do we need a motion to make a motion?
No, you can make the motion to affirm.
I move to approve the budget as presented to us today.
Okay, I have a motion. Second. A second by Leonard. All right, I'm going to ask a show of hands on this vote. So all in favor, say aye.
You said you're going to ask for a show of hands, and?
Yeah, both. Show of hands and aye for audible and visual. Aye. What is it? 1, 2, 3, 4, 5? It would be members of the board. So hands up is 1, 2, 3, 4, 5? Okay. That motion fails. Wait, no, that passes today with quorum. So, okay. Thank you all for that very much. We'll move on now to reports and updates not requiring action or approval, and we'll talk about our favorite master facility plan. So if the team would make their way up, I'd appreciate it.
All right, good morning. We're still in the morning time. Cameron's going to lead off here to talk about our master facility program and our progress.
Good morning. Again, my name is Cameron Gertzema of Broadus Levis team, and thank you for the opportunity to provide this month's update for the JPS Master Facility Plan program. What we have are 4 slides to present. One will be an overview of the program for discussion, and then we have 3 dashboards for active ongoing projects. In the future, I'll look to energize those projects that are in design and provide an update on the status collectively so you can see the entirety of its program and the effort that's underway once we start moving into those phases, and I'll talk about that here in a second. For the first line, for temporary parking, as briefed last month, right now, this is in operation and recurring maintenance continues. Working with JPS right now just to continue to assess not only with reoccurring maintenance, but also traffic flow, pedestrian safety, and just ongoing construction operations in and around the area to make sure that what we have provided and continue to provide is a level of service commensurate with the JPS campus. For the next 3 projects, you can see on there, and you can read kind of the quick hit status for the Medical Home Southwest, the PEC, as well as the parking garage. Those are the 3 dashboards, so if you permit me to hold, I'll go to those in the subsequent slides. But what I would like to be able to provide is just a quick update on the progress associated with the medical outpatient building, the CUP, and the hospital. As we've been through reset, kind of now re-energizing that effort, bringing the team together, and continuing to move those projects forward within the program. So for the medical outpatient building, we are in that programming and design phase. We continue to focus on finalizing the program and the budget, whereby we are optimizing and refining the program design for said facility. Major efforts underway working with the architectural engineering firm, as well as onboarding the general contractor for this effort, and the JPS Enterprise Consultants. As that team comes together, we're looking at the efficient design of that facility. And what's important about understanding that is that project in and of itself is important for the reasons that it's being created. It's also zippering, if you will, and synchronizing with the hospital team. So we're not looking at them solely as projects, but really looking across the campus and the near synchronicity that we should be able to achieve between the hospital as well as the MOB. Secondarily, the CUP, similar to the MOB, was continuing to focus on the program as well as the budget, and we're aligning those as we move into that design phase. We're still in schematic design and concept, but as we work with Jacobs, which is the firm for the architectural engineer, similar general contractor for both the MOB as well as the CUP for efficiencies of scale as well as effort. they're coordinating those efforts with the hospital. So they're watching our concept design that we're going through right now, post-reset, so that as we look at the hospital, and as was discussed and brought up, when we talk about patient care, future, volumes, the JPS executives as well as the staff are intimately involved with our sub-consultants, our enterprise consultants, on looking at those volumes and those key performance units to make sure that we're designing a facility, we're shaping a facility for the hospital, as well as in this case, the MOB, and that it's supported appropriately by the CUP that we're supposed to be building to support the hospital. And so those efforts right now, in earnest in probably the last month and a half, they've been ongoing, but there has been a little bit of a lag relative to reset, and in getting to the point where we would understand that we do have a total project cost, which will then subsequently allow us now to engage these contractors on a level that allows them to start planning effectively within this budget that we have proposed on this slide, but as well as being informed by the future needs and the service that we need to provide to the community of Tarrant County and writ large. Excuse me. So I would say where we stand, and with conversation that I've heard received from my end relative to the importance of the JPS master facility plan and the budget and the focus to achieve said budget, is that the next 3 months are critical to finalizing these teams' efforts. So when you look at the hospital, we are doing this concept design to shape that hospital. So the inputs are coming in, the architectural engineering team is shaping that hospital based on the feedback provided by the executives, and then what that'll end up doing is informing the schedule as well as validating that budget. The budget is the budget. I've communicated this budget with our contracting partners. They're very well aware at present, as I stated last month, indications are still that we're on target. The issue for me is just making sure as we bring those teams on board and they put the shovel in the ground and we finalize those drawings, that we continue to progress, on schedule, on budget. And I do agree, this is something that I will be working with Rory. Rory has asked this, as well as Jill, as much as last week, that the importance of, and so I'm working on this over the next month, is that looking at the cash outlays associated with this budget. We had something at 1.5. We need to adjust that to what 2.1 means by project, by program over the course of the program. The program initially was in January of 2030. There's some months that will slip, as I stated last month, but we can work with these contractors to try to bring that back. It's still within the 2030 timeframe is what I see. I just don't have a month specifically until I get that general contractor, the CMAR, on board and partnered effectively. But I can, in the importance of this program, is take that total project cost, continue to work with one of my sub-consultants, break that out by pre-construction design, construction costs, medical equipment, IT, campus-wide support, work with Rory on what is that cash outflow, or the outlay, excuse me, and work with his partners as well as Price Water, and try to make sure that we're planning and accounting for that as we move forward in the future.
Can I ask a question? You've got
Absolutely.
eight projects here, or 7, and the first 4 are pretty much on budget. A couple are under budget, the temporary parking and the PEC are under the original budget. The other 2, the medical home and the new parking garage, are very close to the budget. Why are the 3 big projects, the outpatient building and the utility plant and the hospital, 50% or more over budget? Is it the original budget was simply invalid, or the scope has changed, or is it inflation? Why are those 3 projects so over budget?
All right, so several factors, so thank you for the question. One is that initially when we go with 1.5 billion back when that was devised, that was a rough order of magnitude until you bring your contractors on board, until you have your contractors assess the risk associated with the actual costs, then they can validate those costs. Inflation is one, market escalation is one, oversaturation of the market relative to the capacity associated with the construction industry right now, not only in Dallas-Fort Worth, but as well as the state or the Southwest. Billions of dollars of construction are going into our overall business environment, our economic development, not just Tarrant County, but everything. So whether it's semiconductors, whether it's hospital care, whether it's large infrastructure programs, that drives where contractors bid, that drives where contractors will assess their ability to perform successfully on a project and whether they will bid appropriately. So there's a piece of all of that that comes together. One of the other things is that as we had a program that had multiple, more projects listed in there. Demolition, campus-wide, program-specific projects, whether it's landscaping, trafficability of pedestrians, trafficability of vehicular traffic, whether it's IT technology upgrades. There are things that go into this, so we've consolidated some of those costs that now have kind of increased in some of those buckets that you see. But largely a lot of it was COVID to escalation and oversaturation of the market that just overcomplicated these prices. And we're probably 4+ years down the road when you talk about inflation as well. I mean, that long answer, a lot to that answer, but the quickest I could provide, sir.
I think too, the more complicated projects, we're just now getting started.
That's right.
And those are also the most costly and where we've seen the most increases in costs as well. Those other projects, you remember, we started kind of long ago. We also pre-bought kind of long ago as well. But the more costly projects are the ones that are coming on board now.
Thank you, Jill. And I would say that when you look at those rough order of magnitudes, you're looking at square footage, you look at largely large facets of the building, but you don't necessarily, you look at complexity, but might not take into the totality of a complexity relative to a contractor bid on that, or the market environment, the changes when you talk about mechanical, electrical, and plumbing, which is as well as steel and concrete right now, that are very heavily priced items. Relative to where we are today and where we were yesterday. But as we move forward, I am, one of the meetings that I've had in the last several weeks was with Austin Commercial, the CMAR that we brought on board to run and build this hospital, as well as with the architectural engineering firm Beck. And Beck has several other partners to execute this hospital, is that their estimates, they went line by line on an exhaustive spreadsheet that gets down to very specific site superintendent detail. And their assumptions were very similar, exactly the same, if you will. Now, costs change a little bit, but overall costs relative to what I'm seeing here and what we're proposing is very achievable from what I'm seeing today.
You also asked about scope, so I want to make sure I answer that question as well. We have not increased or changed the scope. Back to Cameron's points earlier around KPUs, so those key performance units, how many beds do we need? How many ORs do we need? We used a firm previously, Guidehouse, to help drive some of those decisions, and nothing has changed. We refreshed our information and refreshed our data, but we have not expanded scope or done something we didn't contemplate previously in this particular project, so.
Roger, can I make a comment on this? I think, again, the history on this is important. When we originally we're under, in some cases, on, quote, phase one. Phase two was a swag. Honest to God, it was a swag. It's probably going to happen 7 or 8 years from now, and maybe hospital costs per foot are $470, or maybe they're $800. Nobody really knew. So, and unfortunately, nobody in this room at a professional level can sit here and tell us exactly why that estimate was as low as it was. I think looking back on it, I think some of that was, there was a worry about sticker shock even 5-6 years ago, because those numbers could have been so high that there may not have been any justification for it. So I think because they were projected out a much longer time frame to be constructed, those numbers were much, much less accurate. And frankly, I was more concerned about the central utility plant budget than I was the hospital construction, because the central utility plant, if you guys remember, went through several different iterations. At one point in time, the central utility plant was going to be a cogen facility, and there were these incredible estimates of revenue associated with cogen that were then netted out against the overall cost that made the cogen facility much less expensive. Well, that was fantasy. That was fantasy. It was fantasy. So when you went back and said, okay, take cogen revenue out, take cogen cost out, that's the real, when you talk about the budget blows, if you will, that's why the CUP is so far off. And the others are just because, honestly, I think at that time we weren't going to get a great budget estimate no matter what we asked. Just perspective on history.
Are doing something with privates for
There's a
that,
P3,
for that medical
idea where they were
outpatient
going to
bill.
cover capital costs. That's right. And that was vetoed at multiple levels, by the way, including Commissioner's Court.
Yeah.
Yeah.
Totally agree, Trent. There were a lot of assumptions based on where we thought we were going to. Why?
Wonderful.
3 billion.
Doubled.
Yeah.
So Trent,
And also,
sorry, Karen.
I just wanted to give context also, just for people understanding, like parking garages, temporary parking, things like that are so different in construction under the regulations of how you construct a hospital, including oxygen lines, gas lines, all of the different required piping that goes in, as well as the air conditioning, all the things. It's a fascinating education. It's a very small niche community. So yeah, like of people who can actually do that and do that effectively. And they're all booked right now too.
So just to get a clarification, is it true that the central utility plant's original budget was net of projected utility savings?
When you looked at the actual estimates, there were always P3 costs built into the net budget. And P3 costs included capital participation by outside entities from which we would have them build it and we would quote rent it and they would operate it. And that was, by some of us, rejected from the very first second. And with others, it took a while. But Blake, that's why that budget is just so wonky.
Interesting. Okay, so how confident are you that the projected budget, the $2.1 billion, will be sufficient?
To build us a facility associated with what we've designed by scope and requirements. So they're coming to the table, they know these numbers, and they're partnering with us in designing to that. So by all accounts, we can do it.
Does this budget include contingencies?
It does, yes, sir.
What percentages?
It depends. Right now, we're working through those contingencies. I'm looking at what we're seeing in the market. We estimated for the PEC, the medical home, as well as the parking garage. There's is it 5% owner's contingency, 5% kind of construction contingency, kind of standard for the industry. We're assessing that right now on what we saw for change orders. Were those change orders, will they be applicable to the site surrounding area, as well as what we're seeing in the market. And so we'll probably hover around that right now. I don't know perfectly what that percentage will be when we end. Yes, sir.
I think Leonard really asked my question, but in the cost projections, so wrapped in those contingencies is when the city makes building code changes. I mean, I'm saying that from past experiences in building what we projected, and then they changed the codes, then we had to go back and make some changes. So hopefully that's included in that.
It is, yes, sir. Yes, Reverend. So absolutely. That as well as any kind of potential delays, just assuming that we always advertise certain timeframes and we have key performance indicators that keep us to submittal reviews, RFIs, or even working with the city or an outside entity that has interest in approval. And so we understand those timeframes as well, because that does impact the schedule and the contractor and their performance. Yes, sir. So the next three slides that I have are the medical home southwest, the PEC, and the garage. So for the medical home, no change to the budget, and we're holding well. Commissioning, this is air handling units and drying in the is planned and scheduled. Medical equipment, as well as furnishings and furniture are being ordered. Landscape is in progress. You can see it out from the front side of the building. It will continue around to the back during this upcoming month. The building envelope is mostly complete, will be completed within the next month, so it'll be completely dried in. That'll allow us to bring on permanent power as well as start up our commissioning process and get the building to the right temp and the right temperature and humidity as we move forward with finishing out the inside. One of the other pieces I'd like to add is we are working with JPS as well as the city on the bus stop and in coordination of a bus stop just out front. So we're working with them. I imagine that'll be established by the end of the year based on city feedback, but they are aware of that requirement and they have committed to making that a reality. And then we're working with JPS executives on future opening as well and how we're going to conduct that. Next slide. So the PEC, no change to budget, we're holding. So taking lessons learned from an enterprise consultant for the medical home, moving that over to this facility, which is just behind on opening, several months behind, not behind schedule, but behind on target to open later in the summer, is that we're learning from those commissioning schedules and working with the partners and translating those lessons learned so they're lessons applied and leveraging the successes. Medical equipment and furniture is being coordinated and moving forward, as well as an enterprise consultant that we're learning from the medical home and applying those same principles moving forward to future projects. Building envelope is mostly complete. I'm looking at the next month where that'll be complete. We'll be tying into temporary power to permanent power in the coming months, but more importantly, really focused on separating Trinity Springs and back into a whole and complete project here by the end of the year, which is every bit of our focus right now to make that a success. Then the project will follow writ large, but we're looking at the summer of '25. The new parking garage, I think everyone can see how quickly that's going up. I mean, they are flying through progress. What you see out there right now is that offsite about 3 miles, we have all those concrete structures offsite prefabricated, as I briefed last month. Working with JPS, the city of Fort Worth, and the community around us, our ability logistically to bring in those double T's, if you will, for the platforms of the garage and the columns without any issue to date has been a huge success for the contractor and JPS, and we partner with our community. And you can see what you see right now is a block that we'll call that block 1 of 12, 11 more to follow as we build out that garage. And so that's basically the height, and then add 11 more of those. So the thing that will follow between now and the end of the year, maybe into the beginning of next year, but scheduled, and we're on schedule. In fact, perfectly on schedule, is that by the end of the year, we should see the garage in its entirety. And I've asked the contractor, just so everyone's aware, as you see that stuff go up, is how are we impacting the community? I know there's other construction in and around the area, and making sure that we're not impacting them, as well as their safety's being taken care of. And as quickly as that goes up, we'll make sure that we're watching their progress so they don't get ahead of their skis, if you will.
Cameron,
Yes,
I
ma'am.
wanted to congratulate you guys on the parking garage, because in its current state, it's better than what we have right now.
Yes, sir. Right. Amen. Thank you,
I
sir.
think, I think our staff would agree, so thank you, Trent.
Make a comment on your report. Blake, when you were asking about looking at quarters and how it's going to be paid, they've done a projection of what our cost is. Then they actually show us as they go through our actual cost. And looking at this one on that new garage, it looks like the second quarter of 2026, their projected cumulative would be 92 million. That's when that would be totally what they were paid out. If I'm reading this report right, correct? So Trent asked for that some time ago. We never look at it, but I do. But he asked for them to show that projection of when that cost was going to occur. And so that's when they started adding this to this report. Okay?
Yeah.
Yeah.
That's an actual report.
Yeah.
And I'll actually give our friend Mr. Zimmerman credit.
Yes,
for that,
yes,
because
Zim
he,
did,
he
yeah.
pushed that, and
Yes,
Rory and company figured out a way to show it, so.
Yeah.
Absolutely.
I mean, everyone has been concerned about making sure that we knew where the dollars and when it was going to be spent. So it's a good report.
Thank you. Thank you, Cam. We're going to switch over to Rory. He's going to talk a little bit about this spend and where we are currently.
Yeah, thank you, Jill. As Cam mentioned earlier, he is working on a much more complete by project, by quarter cash flow spend on each project, but we did want to bring forth today at least what we have spent. It's a much more simplified, kind of boiled down version of what we have spent on these projects, and of course a breakdown between the bond funding as well as the cash. So you can see those two sets of numbers there, and we will expand on this with much more detail, but today that had been asked for, what have we spent to date, and it hasn't really been put forth in a viewable format, so we wanted to do that today and answer any questions you might have.
Thank you. We'll look forward to, as this gets refined and see it regularly. All right. Any other questions in regards to the master facility plan?
Just one.
Yeah.
Rory, this is a question. When we look at the bond issuance timeframe, and we look at our current cash, and we're contemplating impact on interest, not just our interest rate of the bond, but interest rate on return. Do you see us changing, and Jill, this might be for you too, do you guys see us changing our scheduled bond sale dates on any of these and moving cash to the front of the waterfall, or do you see us staying on the current debt schedule in terms of that plan?
Just so I can.
Well, I mean, we've certainly not sold all the bonds that were authorized, right? We've only had one tranche that we've actually sold. So the question is, the next sale, the next tranche, that's the question that and as interest rates change, that's obviously something where we have to be able to apply the cash at the right time,
Right.
as opposed to the issuance. So what's your thinking right now on that?
At this time, we would not project changing that issuance date. It would be in 27.
Okay.
That second issuance, that would be $350 million. So that would get us to the 800.
So we continue just to draw down cash until then on the current, on not the debt service on our current obligation, as well as cash to cover gap, right? But then you're saying at this point, don't contemplate changing the second issuance.
Correct.
Leave that date the way it is.
Correct.
Okay.
We have I think it's a little bit of misunderstanding that we're just spending all bond funds in this first phase. There is a mixture of cash and bonds that are being spent.
Right.
We would continue that plan at this point.
And that's the question is, if we need to change the strategy when it comes to the second issue, it's a second sale, if you will, come back to us and let's talk about that. We may have to have Mednich and Laura and others here to help us work through that. But I just want to be certain that we're sensitive about the interest rate impact on that when we have cash as an option, as opposed to maybe putting that sale off, depending on interest rates at that time. And then if we get to a point we slow schedule, then it's a whole different ballgame. But I certainly do want to see the options when it comes to when we issue versus cash.
Yeah, it's a valid point to consider. We may be able to keep that cash earning a higher rate than go ahead and spending it down right now.
Right.
Yeah.
Yes. We absolutely do. But as we've looked at changes in project and we look at the current anticipated budget over original budget, that question of when cash is going to be applied versus when the second tranche needs to come in is an interest rate sensitive answer. And I just want to keep that before the finance committee and make sure that we're in a position to look at options if we have any.
It might be helpful. We do have a spread of showing what we projected to spend in cash by project over the next 3 years. To look at that, just as you're asking, just look at that as a group.
That would help us. I think let's bring that back and look at that. Thank you.
Any other questions regarding master facility plan? Great, thank you all. Oh.
Another word for crane, installation completed or operational, instead of the word that you guys use?
Yeah, absolutely. We can look at that.
Would that reflect?
Yeah, that's just standard.
Okay.
That's standard terminology associated with construction or and engineering, but we'll look at that.
I would prefer crane installation completed or operational or something like that.
Okay. Thank you.
All right, thank you for the presentation. Rory, can we talk about the unaudited August financial report?
Let's
A couple more
Oh,
items.
I'm sorry.
more items.
Yeah.
I went to the end of oh, there's A and B. Okay, sorry.
Yes, sir.
So we have a couple of recommendations that we want consideration for award for RFQs for two of our enterprise consultants related to the master facility plan. The first one is the award for the RFQ for the technology services. We went through the RFP process and awarded Burns Engineering. We'll be coming back with those actual work packages and actual contracts, but as part of the master facility program, we do bring those forward. So that's the first one. The second one is the award for the RFQ for the construction audit third-party services, and that was awarded to R.L. Townsend.
Okay, so we need a motion for each of those. So can we just approve the recommendation, or do we need to do each individual? Okay, all right, so this is item A. So a motion to approve the RFQ for technology services to Burns Engineering. I got a motion and a second. Any further discussion?
Just a couple of questions. Jill, can you just briefly explain what each of those contracts is for, especially on the construction audit contract? How do those services differ from the audit services of the hospital's general auditor? And that may be a Rory question, but specifically, what does the construction auditor do?
So with regards to the construction auditor, what they do is they work based on what the contract was written for. So the contract has a lot of legal and business points to it and accounting points to it. So they revert back to how was the project spent, the money spent, how were the dollars delineated, and is it in line with what the what the contract was. So they're specifically auditing against what their agreement was and how they move forward with that project. And as far as for the technology consultant, again, it's an enterprise consultant to make sure that we have continuity with regards to all projects. What we're looking at doing is rather than bringing in franchise utilities to provide services, we're looking at having a single point of access to all, I guess, fiber line, if you will, so that when lines go down, we don't have buildings going down. They still have redundant feeds, and so they maintain that. So they're there to make sure that we have continuity between all of the projects and then again, as the campus itself.
Reverend?
Comment.
Okay.
And that is, I'm glad Blake asked that question, but I want to commend our consultants for bringing to the table that we are looking at efficiencies to stay within budget. I think that needs to be complimented because we could have gone down the road and then been hit smack in the face. So I just want to make that comment.
Thank you. I've got a motion and a second on item A for technology services to Burns Engineering. All in favor? Any opposed? Motion passes. All right. I'll consider a motion for the award of RFQ for third-party audit services.
So move.
I've got a motion.
Second.
Second. Any discussion? All in favor? Any opposed? Thank you. All right. Thank you all very much. Rory, your turn. We're item 10C, if anybody's following along at home. Oh, did everybody leave?
Okay, we've got quite a bit of ground to cover after this, so I will get through this as quickly as I can. The important parts about what you need to know for the month of August, we had gross revenues up roughly $37 million over the same period last year. That's $37 million. That's pretty astronomical when you look at last year, August. Strong patient revenues based on volumes, as well as a supplemental funding change in the month of August that we've talked about. From a statistics standpoint, admissions were up 9% over budget. When you look at the emergency department, you see 11,742 visits. If you go back to the beginning of time, you will not find a higher visit count in the ED. I went as far back as I could in the statistics worksheet, and that was the highest ED visit month that we have had. Length of stay, I also looked back 2 full years and could not find a lower length of stay. That allowed us to continue to see as many patients as we've seen from an efficiency standpoint. So continue to see those very high patient admissions, and also we have hit primary care and specialty visit counts for the month of August, both 1% and 4% respectively over budget. So surgery is the one, a little bit of an outlier. I took a deep dive into surgery this month, and it's really nothing that sticks out more than a couple of provider vacancies really driving some of that. And then, PTO in August, I think, is somewhat variable with some surgeons. They still have families, and so we saw a little bit of that in the month of August as well. So, but it doesn't take more than about 60 cases to drop about 4%. So that's about what you're talking about, 40 to 60 cases. And then we'll go to the inpatient section real quick. We do have obviously this yearly look here on stats. I'll kind of let you guys look at that in your own time if you need to, but inpatient statistics-wise, I would point out 2 of the last 3 months we were at that 93% occupancy. So still continue to really have high occupancy. September does appear to be giving us a little bit of some breathing room, so much needed breathing room. Case mix, Dr. Carla Pudi and I are really looking at the trend in case mix. We feel like some of the increase in volume has affected that a little bit over the last couple of months, and so we're really going to take a deeper dive into that CMI and see how those are correlating. And then outpatient statistics, like I said, emergency department, you can see the blue bar is above all year, really. And so that's well documented what we've been doing in the ER. And then also the primary care blue bar starts to catch up here in about the month of April, May, and June is when we should really start to hit those numbers. I will point out for next year, though, we've really challenged ourselves even more in those areas, so to create more access. So that will be something we will be looking at in 2025. Behavioral health, we continue to see the correlation between clinic visits and emergency visits. There's a direct correlation. One is up, one is down. So we are seeing that correlation. And then we did have in behavioral this month, they are pretty much for the month right on budget, but they're actually 6.2% above budget year to date in those clinic visits. In surgery, I did mention a couple of things there. There's been, I think, one loss of a plastics provider, if I'm not mistaken. That's been a little bit of a loss. And I did see one oral maxillofacial surgeon that didn't have any cases for 2 months in a row. So that's kind of contributing to that surgery situation. I would point out payer mix there is very consistent. Patient cash is right at 100% year to date. With Connections membership, I would point out, if you notice that when that Connections low point is there, that is when, around November, is when we started changing how we re-enroll individuals, so it really has grown. So next month, around October, November, will be that watermark where it'll be about 1 year from there. So we'll really have to see how that Connections membership continues to trend. So that policy change that we made will affect that membership number going forward. Our dashboard, really what I would say here is we really only have one of these metrics that's just short of threshold, and that would be that Connections membership. We set a very aggressive target of about 50,000, and we're right. I think we'll get there, and that was the intent, was to press ourselves. I really think we'll get there by the end of the year. But others are meeting either threshold, target, or stretch of those metrics. Again, we do focus on days cash on hand. We have two numbers there. The first number, 225, is our operating cash, and then the 189 is the future fund. So those are two different important days cash on hand numbers. As you recall, 180 is kind of internal policy, as well as what is recommended really from our bond rating agencies to maintain a minimum of 180. The highlights this month for the income statement, really around just payer mix. Inpatient payer mix was up 7.3% in commercial, and then outpatient was up 7.5%. So we really had an improved mix of patients commercially. And then, of course, that supplemental funding of $21.8 million is a adjustment from a previous budget reduction. So we're actually making up for that budget reduction. Next month will be the last month that we'll be dealing with that, and then we'll reset the clock for October in the new year. So you won't see that large adjustment going forward. I would say our specialty pharmacy and that retail category continues to perform well. Year-to-date, you're looking at about, not just specialty, but also retail, 7.2 million year-to-date. And then we also have other operating revenues, which is really that local commitment alternative. Really, it was just a negotiated rate increase on the part of our team members here that created that additional funding. Salaries are really on target, actually 1% favorable for the month, and then supplies is a big contributor this month to additional expense, and that's really just volume. When you actually flex on volume, we're actually a little bit favorable in supplies, but unfavorable in pharmacy. So, but that is why we're seeing that increase to budget. We do see a little bit also in there. We are continuing to refresh our facilities, getting ready. I think we'll start to see that normalize next year. We've done a lot of work around the facility. Joint Commission has continued to push their date a little bit, and so we hope we are getting things where they need to be, and we won't have that expense moving forward. Let's see. Left over on the income statement, investment income, is some kind of fair market value adjustments around bond calculations. As those interest rates are really beginning to fall, we're going to see bond prices kind of work inversely. And so we'll start to see some of those fair market value adjustments. Those are paper adjustments. They're not, but we do book to that every month to keep those fair market value changes in line. On the balance sheet, not a lot here. Me being the AR person, AR's up about 10 million over the prior year, but AR days are still hovering around 42. So definitely have some good results in collecting and not seeing an increase in aging. It's just the high volume that we've had the last couple of months has really kicked up the accounts receivable. Our claim division, I do like to mention them because we do report consolidated. They are spot on budget for the year, and they continue to see a little bit higher salaries on higher RVUs, but they also have a little bit of contract labor, due to vacancy, some of those vacant positions. But otherwise, their expense management has been really good for the year. I'll answer any questions and take a motion for approval of the unaudited August 24 financial statements.
I have a question on the balance sheet.
Yes.
I think we always go through this. Board restricted for master facility plan. That's the future fund related to all the expansion that we just talked about.
That's correct.
And so we booked I guess to our earlier discussion, by the end of the fiscal year, we'll have $200 million more in there that we didn't have a year ago, if I'm reading this right.
Yeah, so if you recall, in December, we've been funding that. In December, we funded $150 million additional into that future fund. But then, of course, throughout the year, you would have earnings on that fund that are causing an increase as well.
And then last year, we just pulled the notes, we put $500 million in there. Is that right? Does that sound right?
I don't believe 23 was the year that we did that, but there was one large year that we did a bigger contribution.
So we're doing all of this and saving at the same time. That's the number we would look at. Is that right?
Which number?
That the master facility plan is continuing to grow by hundreds of millions of dollars every year while we're still continuing to meet our budget. That's reflecting savings.
So we are generating additional funds through cash flow to contribute to the fund, on top of operating the hospital, as we said.
Yeah. Thank you.
Is there a formula as to how much cash we contribute? How's that decided?
So there is a formula, and that formula in the past has been to maintain 180 days of operating cash. So if you go back to last December 24, December 23, we looked at what we needed to maintain operating cash of 180, and the balance of what we had, we went ahead and invested in that future fund. And that 180 days is a board-designated policy. So we do not dip below that, but anything above that, we consider investable for that future fund.
And how did you, is that just historical, 180 days? Why is that the right number?
Well, to sufficiently maintain operations and pay obligations, there's kind of a minimum threshold there we would expect, and also kind of eliminate risk of not having sufficient funding to do that. Okay. So it is historical, but that's why we would do that conceptually, is to not get ourselves too tight on cash flow. It is. The bond rating agencies strongly encourage us to keep that 180-day rating, and as you look across other public hospitals, you'll see some in the 90s. You have seen some in the 40 days cash on hand. So we try to stay at that 180.
Rory, related to that, on your finance dashboard, your cash on hand has two numbers, 225 and 189, and it says future fund is the second number, but I'm not sure. Can you explain those two numbers?
Yeah, sure. So as we sit right now, that operating cash number I just spoke to, we would be at 225 through August. The days cash on hand in the future fund would be 189. It takes about $5 million a day to run this place. That's the expense to run JPS. And so that 225 times 5 million would be about what we have in operating cash. And then, of course, as we look to the future fund contribution in the next few months, we'll look at bringing that 225 down to a more in line with the 180.
It doesn't move it until
December. So the 225 is going back to the balance sheet, is the 956 million divided by your 5 million per day?
That's not in the restricted fund. That would be.
I'm going to current cash.
Yeah, yes. And we have, of course, we have a couple other things in there that's not just in cash. We have operating securities, CDs, things like that. So
do you include that in your formula?
Yes.
Okay, and then the 189 would be the board restricted by master facility plan, 814 million.
That's correct.
Divided by the same 5 million per day?
We use the same number to equate the future fund.
So you could add those two together to say total cash is about 400 days, but I mean, you really, should you even be looking at the future fund and coming up with cash on hand, days cash on hand? Because that's set aside for a completely different purpose than running the hospital.
Over the next few years, that 189 will completely go to construction spend, and so that what's left will be just purely for operating purposes. So I hope I answered your question, but I think that's what you're saying is that 189 is obligated right now.
So what we should look at is the 225.
Yeah, I can't touch that obligated fund to run operations. I have to operate on the 180 or the 225.
Okay, so the 225 is the number that matters.
Yes.
Any other discussion, questions? I'll entertain a motion to approve.
So moved.
Got a motion, I'll take you as a second, Tim. Any further discussion? All in favor?
Aye.
All right, motion passes. Thank you, Rory.
I think I have a couple of.
You got the next things? Okay.
If you guys don't know Phyllis Chambers, she's our new CNO, and she has effectively coined a name for me called the CF No.
Okay.
I say no to her, but her and I are kind of getting used to each other here. So
Remind him that I'm the only one with no in my title.
So Globus is a contract, and I do get frequent questions around, Rory, why are you presenting a somewhat clinical contract? It's because the ownership of those lie in supply chain. But today we are presenting a sole source exemption request as well as the exemption to bid for technology that does limb lengthening on surgical patients. We expect to spend about $450,000 annually and $2.2 million over a potential 5-year term. So that's 3 years with 2 additional 1-year options. And if there's any questions around how this helps the patient, that is our CNO to help me here.
So essentially what that basically does is if you think about a plant as a vine and utilizing a piece of wood to stick in a plant that's a vine, you basically would have that vine growing up a piece of wood, right? And so for those who have had trauma or some deformity even there, it's an external fixator basically that's placed so that the bone growth can continually occur. You've seen the people with the shoe that ultimately is a lot larger. This would actually prevent us from having to do that now with new technology.
Fascinating. All right.
Make
well-
Blake taller?
If I break his legs.
Moved.
So moved. Second. I'll
Don't
consider.
vote against that, Blake.
A true friend, a true friend.
Okay.
I'll consider a motion to the exemption to bid.
Okay,
As
move
well as the pricing agreement.
Move approval of the exemption to bid and the purchase agreement between Globers.
And is there a second? Any further discussion? All in favor?
Aye.
Motion passes. Blake, your legs are safe today.
All right, real quickly,
Item
Dr. Carla Pooty is going to join me on this one. This is a TAVR. We can do a valve replacement now via catheter, and that's the purpose of this contract. He's going to go into much more detail, but $680,000 annually, $3.4 million over a 5-year contract term. Edwards Life Sciences, I'm going to turn it over to him for a little more detail.
For the clinical context, good morning, everybody. There is between the left ventricle and the aorta, there is a valve that's called the aortic valve. Over time, this valve gets very tight. And what happens is when it gets tight, the heart is not able to pump blood out into the aorta. So before 2000, the only way to treat this condition was actually to do open heart surgery, put the patient under anesthesia, and then replace the entire valve. In 2000, we came up with a new technology where we can actually open the valve through one of the blood vessels, either in your groin or in your hands, I think in your groin. That technology has been available. We have patients who need that care right now, and we, in current state, send those patients to other hospitals to get those procedures. When we do that, it actually causes delay in patient care because the patients have to get scheduled in another system. Our physicians actually go to those hospitals and do those procedures. In current state, we have the clinical expertise, the physician expertise, the lab expertise, the equipment expertise. All that we are missing is a valve. So what we are seeking is the permission to buy that valve so we can start doing those procedures at JPS. It will be a new service. It will decrease the amount of time our patients spend trying to get these procedures significantly. Our patient outcomes will be better. So that's the clinical context behind this valve. Happy to take questions. So the technology first became available in 2000. It became widely used in 2010. So we are about 14 years behind.
And so to answer that question, the lack of this ability and some others that we're really talking about as well has significantly impacted our ability to recruit and retain staff. So we are at least a decade behind where fellows a decade ago were being trained in their training programs.
So what? I do not know the answer to that.
We have finally got the right mix of the people, the cath lab staff, the cath lab itself, the physician staff. I'm going to take this as the opportunity to say we have finally built the team and everything is ready to go.
Which we said, and get this, Trent, we were sending those patients out, but it was creating delay in care, and our surgeons were going elsewhere, so it didn't make sense. That we have more of those physicians who do this procedure, so it's opportunity for us to.
So Daphne, can I make my motion retroactive 14 years? I'd make a motion to approve.
I would like to second it.
I've got a motion, and I've got a second. Any further discussion? All in favor?
Aye.
Any opposed? Great, thank you.
Much like our facilities and
Roger,
IT.
I want to ask the question maybe here, but I should have asked when Phyllis was sitting at the table. I want to ask the what if. If we had not approved what Phyllis was asking for this, is there a financial impact on us?
I assume there would be. I mean,
You still send them out?
I mean, I can only speak to the pro forma that we did for TAVR. It is cost savings for us to do this procedure here. So the financial impact is that we are paying extra to send this to another facility to be done. And we would continue to do that because it's the right thing to do for patient care. The patients need this procedure. But bringing it in-house is a cost savings to the network.
Okay. And nursing is ready to take care of those patients. Okay.
Yes.
Make sure.
And there's more of these patients now, too. I think when it was first brought to us, there was fewer of these that we were actually sending out. And so it did not, from a cost, make sense. So this, I think we have gotten to that point where there's more patients that would benefit from this procedure.
And we looked at that too for due diligence on this. We looked at this not only for the cost of what we paid other facilities to have this procedure done, but in the alternative procedure of doing a surgical valve here. And if you look again from a patient experience standpoint, this is an overnight stay in your home the next day. An open heart procedure with everything that entails is a multi-day stay with a ton of recovery time to follow it. So on all fronts, financial, patient care, just right thing to do. I hate to use that phrase, but.
I wanted to hear you say that. That's why I asked that question. And go back to on Phyllis's item. Sometimes I think the board needs to hear that is a financial impact, cost savings, as if we had just stayed versus how we stayed where we were,
well, thank you. Dr. Davis, thank you for your advocacy, too. That's really exciting. Item F is consider approval of the pricing agreement between Boston Scientific and Tarrant County Hospital.
Yeah, just Dr. Carlo Putti is going to go into greater detail. This too is a newer technology. I hate to say newer because I don't know when this one started. It's referred to as the Watchman procedure. We have not done that previously at JPS. And $180,000 annually, $900K, and RFP was conducted, and Boston Scientific was chosen.
So for clinical context, this is a device that's become more and more. I think started in 2010. It's been I think it's been only 5 years where it's become more globally used. So believe it or not, there is a small part of the left atrium that is actually not very useful. It's actually a vestigial part of the left atrium. In a normal heart, it doesn't cause any problems. But once you develop a condition called atrial fibrillation, where your heart is not squeezing but just fibrillating, that area of the heart becomes a source for clots. And those clots form there, and then they can dislodge and they can go to any part of the body and it causes devastating strokes. So in patients who have atrial fibrillation, we actually recommend that they are on blood thinners because we don't want those clots to form and then go everywhere in the body. There are some patients you actually can't put them on blood thinners because they have very good reasons, because they have bled somewhere else. They fell down, broke their head, they bled in the brain. You can't put them on blood thinners. They have GI bleedings. So in those patients, they are in this hard place between, I'm going to clot because of my atrial fibrillation, I'm going to bleed somewhere else. So to prevent that, what we have to do is place this device in that left atrial appendage and close it. So it's called the left atrial appendage closure device that again is inserted through the groin. It's an overnight stay for patients, and I think in current state, we send a few patients out, but what we are seeing is that there's an increase in those number of patients who have this condition and this bleeding problem. So it's a number that's going to increase in time. And as we looked at our numbers, it is actually going to be a cost savings to bring this device into our facility. We just need the valve, the particular device, and I think the cost savings per device is going to be around $4,000 to $5,000. So it's a cost savings for us. It's the right thing for patients, and it's a device. It's a device we'll use more and more just because of how our patients are. They're living longer with more comorbidities, and something we'll use more. So that's the background behind why this device is needed.
And Reverend Emerson, to the last, we also look at stroke prevention in this, prevention of GI bleeds, the patient morbidity and mortality that you get with both of those. And this was also the other thing that we talk about and being able to recruit and retain cardiologists.
It's also cost savings in future medication costs, because Eliquis and Xarelto, which are the two anticoagulants that we use with atrial fibrillation, are incredibly expensive medications, very cost prohibitive for patients. So it saves them the cost. So even if they don't have bleeding issues, this is a good procedure for them.
If they can't.
All right, I'll ask for a motion.
Is there any staff training necessary to start using this device? And how many procedures a year do you think we'll be doing with the Watchman?
I think there is a bit, so that our cardiologists, our nursing staff, and our cath lab staff are trained. So when we come on with the company, will bring the device, they do additional training. So they are trained to do this. The cardiologist right now does these procedures elsewhere. So we have the technology and the staff training for this. We anticipated, based on looking at this data, that I think we will see about 15 to 20 patients the first year, and over time, we anticipate that number to increase. I can't tell exactly what that is, but the starting number is somewhere between 15 to 20 for the first year once we bring the device in. Thank you.
Is there a motion?
Move approval.
A motion? Second. Any additional discussion? All in favor?
Aye.
Any opposed? Motion passes. Thank you. Thank you all. Joy. Item G.
All right, good afternoon now.
Okay.
All right, I'm bringing forward for your consideration approval of the master services agreement between Relay Care and the district. We went out for RFP for, this is our contact, our phone center, allows additional overflow support to support our team to answer phone calls for patients who need us for scheduling. This cost is included in our approved FY24 operational budget, and I'm happy to answer any questions that you might have.
Blake?
Yes, Joy. In August, we approved, or the board approved a contract with Care Harmony for some, mainly post-discharge care coordination services. And these two companies appear to have some overlap in their services they provide. Can you contrast the two?
Sure.
As to what they'll be doing for JPS?
Sure. So if you think about Care Harmony as kind of, and Dr. Alawi presented as more this proactive case management, care coordination, wraparound support of our patient population, outreach in that sense. What Relay Care does is they literally are an overflow to supplement and complement our current call center staff. So if you call to seek care at JPS because you don't use your MyChart to schedule directly, then you would call and speak to our team, and then this team provides this supplemental support for holidays, weekends, overflow hours, so that we can make sure we maintain a certain level of service of average speed to answer and hold time. So different in that space. Does that help clarify differentiation?
Yeah, I did. I think that they do compete in some areas. I just wondered what each would be doing for us.
Right, so this scope of work is really those people that you would call, I'd like an appointment to see Dr.
Okay.
Fowler, and I'd like to schedule that appointment. Those are that supplement to our team.
Thank you.
I'll seek a motion to approve. I got a motion by DT, second by Dorothy. Any further discussion? All in favor? Any opposed? Motion passes. Thank you, Joe.
All right, this second agreement that I'm bringing forward for your consideration for approval is between Prodigy Health and the district. So essentially, this agreement provides an inventory management solution for blood-derived products. So essentially, it's temperature-controlled RFID cabinets that house factor products, things of that nature that are extremely high cost, but also unpredictable in demand. And so they carry the complete risk to make sure that nothing expires, and they only charge us for what we use. So through kind of a midnight rule, as we use those blood products for our patients, then we're charged when it's pulled from that cabinet. So really helps JPS from cost containment. So we don't just order, have this high cost drug, it sits on a shelf, it expires, it doesn't get used. They're maintaining and monitoring that for us. We went out for a bid for this. We went with a new vendor because we did see opportunity, and this Prodigy presented the best value for JPS. Yes, and again, for the factor products, I'd bring in our specialist on 340B, which I see Nicole back here. Yes.
Prodigy's not providing the blood products, they're just doing the storage and the inventory management. Is that right?
They actually work through, like Morris and Dixon, through with us to provide that. So yes, they do.
So this price include the blood products as well as the storage and inventory management?
Right. So they're managing, and then that charge for those products. And so that listing has a schedule of those different blood products.
But these are products that we don't obtain through Carter.
Correct. These are. It's not whole blood, it's not plasma, it's factor, it's, Nicole should be very proud of me. I mean, Nicole, I don't know if you want to come up here and answer any other questions, but I'm right, Nicole, is there anything else that you can?
No, it's primarily the factor products, and then it's really a consignment arrangement.
Mm-hmm. So, yes.
And this is a service that we currently have. We're just using a new vendor.
Yes, yep, went out for bid, so.
Any other questions? Seek a motion? Got a motion, is there a second? Got a motion and a second, all in favor? Any opposed? All right, motion passes, thank you.
All right, this next contract is I'm asking for your consideration of approval for First Amendment to our professional services agreement between Maxor Pharmacy Services and the district. Essentially, this agreement provides expansion of specialty pharmacy services and increased scope of work related to the additional expansion for our master facility planning. So MOB, Medical Home Southwest, as well as correctional health, so expansion of service support of our pharmacy staff and team members at the jail.
Okay, so my question here is Maxwell providing any product with this contract? And then can you kind of distinguish between the services that they provide and our in-house pharmacy staff provides?
Yeah, sure. So Maxor provides us that oversight of management, and it does, when we say management staff, that does relate to actual pharmacy managers. So that is FTE, that is in that cost there, that are being, that are here at our location. So at the jail, as well as at the jail services, even some of the tech staff, that is actually Maxor staff themselves. This is not drugs, this is just purely staffing and support services in that space.
I'll ask for a motion. And a motion. And a second. Any further discussion? All in favor? Aye. Any opposed? Motion passes. Thank you, Joy.
All right. The next one is, I'm considering approval for exemption to bid and an addendum to the purchase agreement between Parada Systems and the district. This does carry an annual maintenance for software maintenance cost for our cabinets that are automated for dispensing, labeling, really helps us to provide an efficient service. We are asking for exemption to bid because we currently have Parada, we have that interface within our systems for IT, and this helps us to supplement with what we have currently that our staff is very knowledgeable and knows how to operate, and to bring this expansion into our jail services. And so this would provide 3 cabinets that would provide these services for pharmaceutical distribution at those sites. Yeah, I mean, automation does help us from a volume perspective just in general, so it's the way to go. But it also provides those safety and quality aspects that we need for, maintaining that we got the right drug to the right patient at the right time. And essentially Talus, this previous vendor that was in the space within jail, was sunsetting, and it was an opportunity for us to align all of our systems so that we have what we have here is also what we have at the jail.
Second.
Thank you. I'm trying to figure out how this machine works, is what's going through my mind, so that'd be an interesting thing to see. Okay. Yeah, field trip.
Yeah, you should come. Yeah, retail pharmacy. And again, I'm glad Nicole's here, but just, that automation of the medication coming down, it's labeled, it's printed, it's scanned. I mean, just all of that. And it just brings that efficiency to the workflow for the team.
Okay, great. I've got a motion and a second. All in favor?
Aye.
Any opposed? Motion passes. Thank you.
The next one is consider approval of Fourth Amendment to our landscape service and maintenance agreement between Superscapes and the district. The purpose of this amendment is to allow for, the support of landscape maintenance across all of our JPS network locations. And so I'm asking for seeking your approval for amendment to this contract.
A question here, Joy, and there was an exhibit on the board portal, it's not on our iPads today, that showed a list of all the facilities and a cost for each facility, and it said, most of them said that these were basically flower bed overhauls or reconstructions.
Yeah, so it's basically additional removal of, dead plants and redoing all of that landscaping and maintenance. And also from a safety perspective, you go out there and roots are sticking out, tripping hazards. And so it was to really make sure that as patients come in, it really reflects that we're ready to care for them, that we, take good care of maintenance of our properties from a safety perspective, and was basically overhaul of these sites.
But this contract is just for the overhaul, it's not for any maintenance after that project is, each flower bed is rebuilt?
Correct. We are going out for RFP, and so this is to kind of help to get completion of what we need to have completed as we go out for RFP for this upcoming year.
And I think there were like 20 projects on that list. I don't know why it's not here today, but
yes.
But each one was, they range from $11,000 to up to $40,000. Now, I'm just thinking about, hiring a landscape firm to do work around my house. $40,000 would be a lot of landscaping. And this wasn't bid. This is just an amendment to an existing contract.
Yes.
So we didn't go out for bids on any of these items. They just gave us quotes.
Yeah, right, correct. So they were awarded through RFP, and then we asked for scope of work for additional services. And if you think about some of these, like full medical homes, like the full surrounding buildings, the behavioral health sites, these are, corner lots and adjacencies. So there is a lot of square footage. That's really, when you think about all of our network locations across all of the county.
Okay, those are my questions.
I'll seek a motion. And a motion and a second. All in favor?
Aye.
Great. Thank you. I just want to make sure we go back to item J. That was a approval of the exemption of bid, and, okay, I just want to make sure that we covered that. All right, thank you. Well, Joy, you won the award for spending the most money, I think, so congratulations.
He always does.
Shannon.
Good afternoon, everyone. I'm bringing forth for your consideration approval of an amendment service between the district and IntelliMed. IntelliMed is our data market analysis survey that's used by the Office of Strategy Management. It really allows us to analyze the needs of our community, any growth strategies for the future for the network. As you all know, at the top of the year, we will start a refresh of our strategic plan, which concludes this year. And so using machines and actually data analysis tools like this will allow us to refresh that data to make sure we're meeting the needs of our patients and our community for the future.
Great.
It's a software data tool, and so our Office of Strategy Management can pull data related to payer mix, demographic data, just to see what the market landscape looks like from a strategy lens.
See, do we want them to be a part of our network, analyze our contracts to see if we're profitable day one when we add them on as we look at the market and everything else?
Is it from a provider perspective, or I'm sorry?
Beyond that, right, from the patient perspective, but also provider, where we have gaps in it. Do we want to recruit them? What's the existing contract look like versus ours to see if day one would make money or not, type thing?
And I know, like, in finance, Roy can chime in on the finance lens. I know we do some things with Will's team in terms of internal for provider data. And so, but this is external market data in terms of where we look at from a community perspective and demographic. Yes, sir. Mm-hmm.
You're looking at?
Yes.
I'll seek a motion.
Move approval.
In a second. Any further discussion? All in favor?
Aye.
Any opposed? Great. Motion passes. Thank you. Thanks, Shannon. Mr. Showalter. I start shaking when you stand up, so.
I'm bringing two contracts. It is a document management system. It replaces both ChartMax and Celerity. It provides document management, OCR, and indexing. But there's also some additional benefits. We'll be able to do order level scanning, real-time chart correction, and duplicate tagging right off the bat. The software costs $122,000 per year. We're paying $243,000 for ChartMax, so there is a considerable savings. Questions?
Does this include storage also as well, or just the software and then the storage are considered differently?
No, this does not include the storage.
Okay.
But I'll be talking about storage in a minute.
But wait, there's more.
That's pretty cheap for that.
So there is a cost savings of about $121,000 per year by switching.
And so we're offloading two software programs and going into one?
Yes, sir.
So this is strictly for like indexing and type thing, or?
It's for document management proper, it's for the OCR capabilities, and it's for indexing the documents as well. It'll do all three components.
Does it include the capability of looking at the doctor's note, handwritten, all that stuff as well?
So there's no this is pure document management. There's no AI built into this.
So a different module, if you want to lift that up, we have to have NLP or AI?
No, then we'll leverage the components of Epic that are being brought forward.
Do we have it yet, or we about to get them?
We will get them as soon as the infrastructure is prepared to be able to handle them, and that's my next request.
Oh, I see. Okay.
Okay.
Question, so Epic's already providing our EMR.
Correct.
So this is adding to what it's already doing?
That is correct.
Can you just, and it kind of explains here on this summary, but can you give a little more detail what new services that it will provide with Gallery?
Sure.
That we're not already getting?
So order level scanning is one thing that we can't do at this point in time with the existing technology. Real-time chart corrections can't be done in the tool. It has a loop system that's got to go out, be manually touched, addressed, and et cetera. And then the third is duplication of duplicate flagging can be done within the system, which is a manual process right now.
And is there some additional information provided to patients also through Gallery?
Again, this is the document management, this is the storage component.
Okay.
Not necessarily the artifacts themselves that go out to the patient. That patient information has come from the medical record proper, not necessarily the storage unit. There are links for various documents that may be part of that request for information, but it's not part of, it's not something that's given to the patient.
Is it fair to look at, is it like a traffic cop, indexing and all that stuff?
Yes, sir.
Controlling, okay. But not the content itself?
It's not delivered, it is storing, just storing content.
So the only, and then we're adding on scanning capability.
That is correct, by eliminating the other tools.
Any further questions? I'll seek a motion for exemption to bid as well as the agreement.
For approval.
Got a motion? And a second? Any further discussion? All in favor? Aye. All right, thank you.
All right, so here comes the excitement. So I'm asking for a contract with Innova Solutions. They're going to be the system implementer for our Azure cloud environment. It's an $18 million ask, and let me put it a little bit in context. So let me explain what cloud is first. We're all familiar with data center on premises, and we have full responsibility for the hardware, the refresh, the cost per square foot, which is the power, HVAC, batteries, UPS, batteries, et cetera, and then the management, the functions of doing firmware updates, upgrades to operating system patching, et cetera. We have colos. The colos, we have full responsibility, except we're paying for the third party to manage that cost per square foot services. Cloud is nothing more than infrastructure as a service, where the vendor has all full responsibility for everything we just talked about, the hardware, the refresh, the cost per square foot, and the management. So what we're trying to achieve here is a value in relationship to the total cost of the total cost of ownership and the reduction and elimination of our technology debt. This gets us out of the data center business. This gets us out of a CapEx management for typical data center activities, and it puts us in a predictable economics. The bigger issue here is the high availability, the security services that it provides in addressing some of the opportunities that we would have to address if we didn't go to the cloud. This has been about an 18-month journey. We started with a defined strategy. We've spent a lot of time in terms of looking at the architectural requirements, the compute requirements, the storage requirements, et cetera. We did discovery between Epic, Azure, and AWS. We established a game plan. We went to RFP, and now we're back with the finalization of proposed vendor and the contract. Now, I'd like to explain the cost of this a little bit. So this is an $18.5 million project, and you got to understand that $18.5 million is really in two buckets. The first bucket is Epic itself, and we run an active environment, which means that one's always on and available for the disaster recovery, so it can flip. The second bucket that we're going for is the ecosystem. There's about 63 applications. Everything from 3M, Philips, PACS, the interface engine, blood bank, all the ecosystem that needs to be moved with Epic. So those two buckets make up the total cost of the project. Now there's a transition phase. So while we're doing this, we still have some costs associated with the Alliance data center. Twofold, one of which is making sure that we've got storage and space to be able to move things back and forth, because we have to move it from existing systems to a holding spot to the new environment. As well as we have actually a third bucket. So as we start talking about the cup at some point in time, there is no need for a data center once we go to the cloud. So we have a third bucket of applications that have been told that have to remain on site, nurse call being one of them. So it'll take us 3 years to basically go with each vendor and have the conversation, do you have a product that's cloud ready? And if not, then we're going out to RFP to find a cloud-based product. So we have the Alliance Data Center that will be with us for 3 years. There's still a bit of refresh storage and backup that has to be done in terms of build out and be able to make all this happen. So the overall transition cost is about $29 million. Now, if we were not to change the existing environments and we still had our colos, and we're still doing the refresh, that's about $40 million over the course of 6 years. So we're looking at a $2 million savings. Oh, yes.
Yeah.
Yeah, and some of them beyond that. Oh, everything will be mapped out. Yes, sir. Yes, sir. So in the last page, I think graphically I can explain what we're trying to do. The red is the history, and we have not actually invested that much over the course of the previous last several years in terms of our technology debt. The orange or brown or whatever that color is expected, and that's what we should have been doing all along. And we've missed several major upgrades or refresh. One within the Epic environment itself, which would have been the IBM server computes, the P8s that we have existing now. And then the second would be in the data center where we're actually looking at refreshing in the virtual machines, the servers that house all the virtual machines. We have not done those. So the proposed plan to get us there is the cloud conversion, when we actually catch up with the technology debt and then get into a position where we're offloading that debt to a third party to manage that from here on out.
Let me try to understand this a little bit better.
Yes, sir.
So is this the conversion to a new place?
Yes.
To get rid of some of our technical debt?
Yes.
Or does it combine with some upgrade to the EHR?
It has nothing to do with the EHR. So for instance, the Epic refresh, we currently run IBM Power 8 servers. We put the Power 8 servers in 2015. They came on market at 2012. So by 2015, they were mid-product, midlife equipment. Those things have not been refreshed.
Okay.
And they've been running as is since 2015. So ultimately, what we're missing is 2 refresh cycles. This allows us to catch up with those 2 refresh cycles and then gets us out of the business of having to plan for the capital to do additional refresh cycles because that's already built into the contract.
But once you move it over there, the total cost of ownership will decrease, but at the same time, it will increase over time because of all the
significantly. If you look at the outward lines of 28, 29, and 30 in green in terms of the proposed level, you can see that drops to about that $3 million, which is the cost of the overall contract.
What I'm trying to get to is that there's a lot of moving part because of regulation, right? I'm not sure when are we going to be ready to file for the ECQM and all the quality stuff measured. And so that will increase, and also we may have to take in data coming in from ECW, eClinical and all that stuff, Athena, from other providers that touch those patients to be reported by law shortly.
So one of the advantages
have they looked at?
So one of the advantages of moving this is the elasticity of the storage and the capabilities to consume data. The other aspect of this is moving it to Azure, and there's a strategic move to do that. I hate to get technical, but I'll drop back. You know that Epic is in a MUMPS environment, and MUMPS environment is great for scale, but it's very bad about managing long-term data storage. Epic has come to the realization that they cannot manage that storage. In the middle of last year, they launched a program called Nebula, which is actually moving all of the clarity and all the reporting services to the cloud, Azure. So they've come to the realization that they can no longer maintain the growth locally of that storage, and we have to go to the elasticity of the cloud. Now, the elasticity is very cheap. Mm-hmm. We just bought I think it was last month or the month before last, forgive me, we came forward for $242,000 for 1 gigabyte of storage. That same gigabyte of storage, if we don't do the hardware and we do the cloud, is literally about 15 cents because we're paying for that scale. Other questions?
Will?
Yes, sir.
Sorry, did somebody else? You mentioned earlier AWS versus Azure. Does Epic give you a choice, or they just use Azure? Or?
So we looked at three environments. We looked at Epic proper. The problem with Epic proper and having it hosted by Epic was that Epic only hosts Epic, and they don't support the ecosystem. And it doesn't make much sense to be splitting the environments and having multiple organizations and supporting your environment. We looked at AWS, and we looked at we assumed that we'd be making the choice between AWS and Azure, and it really became down to the strategy. The Epic is all in on the Fabric, Microsoft's Fabric, which is Azure based. So we would be, it would make more sense to go down and be aligned to the strategy that Epic went with. Then we looked at overall cost at the RFP, and then we looked at the value, what services were provided within that cost.
So it'll use Azure?
Yes, sir.
Okay, and do these costs include all the Azure costs?
It's in total.
Pardon?
All the costs are included.
Included, okay. So your projection is it saves us $10 million over the next 6 years?
Yes, sir.
Thank you.
On this one, I believe, correct me if I'm wrong, because I've been seeing stuff flying around when we approve stuff. We are on Palo Alto Network Cortex, right?
Correct.
And then this one, when you move to Azure, they're probably trying to push for CrowdStrike or something.
No.
Have all that stuff.
No.
Move that.
No. So from a security perspective, Azure has 4 regions, and they're subdivided so there's a total of 11 capabilities centers here in the U.S. Part of their strategy is to make sure that they don't end up in the bucket like CrowdStrike, where they have all their facilities on the same services. So we would be using 2 distinct U.S. regions, separated, and the regions would have different configurations. Now, our desire is to make sure that we have a consistency of NetApp from a storage perspective to be able to take advantage of the AI that we've already put into an environment. But as far as the Palo Altos, that'll be a discussion when we come back to the MSSP, but we're not looking to change out what we're utilizing. Plus, the other issue is their core infrastructure is managed by Azure, period. We'll still manage our core infrastructure here on campus. So the Palo Altos don't necessarily need to change.
And they can interface with each other without losing.
Yes, sir. Yes, sir.
The other question I have is also so we're moving Epic over there, so they manage the MUM's operating system, hosting all that stuff along with Azure.
Yes, with a lot of oversight from our friends from Verona.
Well, I don't know much about any of this. My computer at home still has Azure computer Y2K compliant, and I know how to use Control-Alt-Delete, so I'm going to leave it to you guys. But I will consider a motion.
Move approval.
We got a motion in a second. Any further discussion? Motion. All in favor? And the motion passes.
Thank you.
Thank you.
Thanks, Will.
It's no longer good morning, Ashley. It's good afternoon.
It's still Thursday?
It's still Thursday.
Good afternoon. I have before you for consideration the contract for fall six. Fall six is the patient experience impact survey that will be needed to take this RFP. The first year with an annual $395 expenditure for years 2 through 5. Total agreement is a 3-year contract with 2 one-year extensions.
Question for you.
Yes.
Is this replacement for Press Ganey or in addition?
It is a replacement for Press Ganey.
The next question is, what about the historical data?
So we will have access to the historical data. One of the limitations of Press Ganey is they really don't do a great job of providing us with visualized data and insights. And so we're already essentially manual manipulating our data using Power BI. And so we have all of that historical data internal today. But we do have a plan in terms of working to make sure that anything that we have currently with Press Ganey, we will own that data, and that data will have an opportunity to be integrated into our Qualtrics platform. So we're already working through that.
Have we looked at some of the key data that they have of Press Ganey? Do we have one-to-one ratio? Or sometimes they move, yes, but we lose a lot of important field that is not transferable over.
So yes, and I will tell you, one of the reasons why we consider Qualtrics is, quite frankly, Press Ganey has market share, but their technology and their ability to gather insights and help us to visualize that in a way that allows us to action to improve our patient experience is really quite antiquated. Over the last few years, they've really focused their strategy around those companies who use both their EX and their PX platforms and really have invested in that side of the business. They don't provide great support for those companies that only use PX, the patient experience portion of their product. We're really happy with Gallup. Gallup has really helped us to elevate our employee experience, and so this time we weren't entertaining kind of putting both of those contracts in the same place. And so when we looked at dollar for dollar our value in terms of insights, capability to action on patient experience, Qualtrics was head and shoulders above Press Ganey.
Metrics that all hospital systems utilize, and everybody knows where they stand relative to Press Ganey scores. We will no longer have that, right?
So what I would say is that they do still have the majority market share. Qualtrics is continually gaining steam, and it is not a small market share. So when you think about, I would probably feel uncomfortable with something like a Tiny Pulse, some of these emerging surveying tools that really don't have enough market share for us to get insights. But I will tell you, market share is a wonderful asset to have, but Press Ganey's ability to help us draw actual insights from what is there is very limited. We are just not able to draw from them the expertise and insights that we really need to take our patient experience to the next level. And I will tell you, I sit on several advisory councils with CHROs and chief experience officers, and it is a growing trend that we're starting to see healthcare migrate toward Qualtrics. They're really picking up steam because of their ability to just provide, quite frankly, superior insights and get people from kind of reactive to more predictive in the patient experience space. Stranger things have happened, but I don't have any indications of that. Any additional?
Do you have any insight with other healthcare systems in various sectors, other large hospitals that do use contracts?
So I think it's a mixed bag. I happen to know that, like Parkland, I believe, is using Press Ganey. I also have a pretty strong rapport with their CHRO, and we're just having conversations about the same thing. That many of them have stayed with Press Ganey because that's where they've been, but they're not particularly happy with the insights they're getting. And so I think, you will find a mixed bag of folks that are using Qualtrics versus Press Ganey. I think in some cases, people are in a space of what I call toleration, where they've been with them for a period of time and they continue to stay with them, but they're not particularly happy with it. And I will say, this is actually feedback that I've given directly to Press Ganey, if you were to be using their EX, and I believe, I don't want to speak out of turn, but I'm almost fairly certain Parkland is using them for EX as well. The experience is much better because they have built an integrative dashboard around both of them. And I will tell you, I'm a kind of EX nerd, and I still don't love Press Ganey's approach. I think it's a very antiquated approach to employee experience. So I still don't think it's the right solution.
Sorry, so with that, clearly we have a great relationship with Gallup. for employee engagement, what's the reason not to use Gallup for this?
They're not there yet.
Okay.
Yeah, they're not there yet. And really, that's not their business. I don't know that they really have as a strategy, really targeted patient experience as an area of expansion.
I just worry that we kind of jump ship, we use Press-Ganey, and then we don't have a way of comparing ourselves to our
So I would say that as we went through the RFP process, and I can bring back to you some specific insights, part of our RFP was really carefully written to tease that out, to understand if we would be able to have the same kind of insights with the folks that came to market. And I will tell you that I think originally we had 4 or 5 vendors approach, and we actually narrowed down based on the answers to those questions. And I'm more than happy to kind of come back to you or come back to the board and share additional insights about kind of the due diligence we did there. But we did do, I would say, more than fair amount of due diligence in determining that we would not lose the integrity of our ability to compare ourselves to our peers, but also gain insights that we need to improve the patient experience through this decision.
I'm not sure we have any contract that tied to star rating that Roy may be looking at. Would this one improve our star rating down the road or have no effect on it, that Roy?
I'm sorry, I'm not hearing you.
Is this going to improve down the road if we, for our star rating and all that stuff as we negotiate contract?
Well, if we do well, it does affect our rate for our star rating. So it just depends. Again, I don't know how CMS pulls
Have we looked at the crossover so that we can just buy something, but it has potential other benefit down the road that we may use for negotiating contracts?
So the short answer to that question is any improvement in patient experience, as Dr. Duncan said, would have a positive correlative effect. Your specific question about a single solution, I don't have an answer to that. And I can follow back up with you and get you an answer.
The CMS
Do.
to give us star ratings?
I believe so.
So the question is, do they use Qualtrics? Do they recognize Qualtrics?
Are we talking about CAPS?
But the caps is caps.
Star rating.
So those questions are statutorily mandated, and any patient experience surveying tool is required to meet the standard as it relates to what CMS requires for any CAP surveying.
They pull the H caps.
Yes.
So they recognize Qualtrics?
Yes, they do recognize Qualtrics, and they.
That's all.
Ashley, there's no EX component of this contract. This is all PX.
This is all PX.
Okay. There's no HR aspect at all in this, I guess.
No, there isn't. I mean, what I would say is that there's a direct correlation. We know there's a direct correlation between EX and PX. And one of the benefits of stepping into a new relationship is that we have the ability this time to configure our user group so that we are now able to do some correlative analysis between the employee experience and the patient experience. And so there's an opportunity. So one of the, Press-Ganey is fairly rigid as it relates to the way you're able to cut, slice, and view the data. And so we have the opportunity with this build to be able to create some correlation so that we can look at the employee experience and compare it to the patient experience, because we're doing it now manually and it's difficult, but what we are seeing is a direct correlation between opportunities on the employee experience side and the patient experience side.
I mean, Margaret, do you have some concerns? Do you want to postpone this or get more information? Or?
Yeah, I honestly don't. I agree with you. Right, I'll push the button. I agree with you. I think Press-Ganey is kind of antiquated at this point, and I like the innovation. I just worry that we're jumping ahead of everybody else. And I don't know if you have the answer to that question. And because, this is how you compare hospital systems to each other, is based on Press-Ganey scores. And so if we're not in that, we don't have a way necessarily to compare, especially if large systems like Parkland, I know Baylor still uses Press-Ganey, if other systems are not on the same measurement standards. So that's my only concern.
I mean, we've got another meeting in 2 weeks. Is this something you want to get more information on? So you're.
Yeah, I would love to kind of see who all uses Qualtrics. I think that would be really helpful to see.
So I'm more than happy to bring back to you a little bit more about their
who uses Qualtrics, but I also will bring back to you how they're able to aggregate CAPS information specifically, because I think that seems to be maybe more of your area of concern.
Yeah, I just want us to have good information, not just internally of how we can improve ourselves, but also how are we compared to other systems?
Absolutely.
Are we on par with what everybody else is doing? And I know that Press Ganey, everybody's kind of moved up, so like, you're failing if you're 94th percentile,
you don't move
right?
as quickly or more. So.
But at the same time, we kind of have to know where we stand among our peers.
Sure. I feel confident that we have answers for you, and that we can get data that will make you put you at ease. So I'm more than happy to come back to the board with that.
Ashley, did we lose anything if we punt this to the board meeting?
So we need to get the contract implemented, but I think 2 weeks is fine. We have given ourselves some time and an extension of time with Press Ganey.
Okay.
And so we're not jammed up if
Okay. Let's just bring it back. We'll table it for the moment and just bring it back to the full board.
Absolutely.
I'd also like to see, we've, because I share the concern too. This hospital has received significant Press Ganey recognition and awards in the past decade. And I realize the evolution of this is probably moving us to somewhere different, but you mentioned that there are some quality analytics that you feel are superior. Could you bring some of those back to us?
So I certainly can get with Qualtrics and get you some dashboards so you can see some visual demonstrative, some of the stuff that they demoed for us.
Great.
I'm more than happy to do that.
Perfect.
And I would ask that you show what is their market share out there. Yeah.
You have something else, Dorothy?
That's it.
Okay.
That's all I had.
All right.
Okay. Thank you, Ashley.
More to come. Thank you.
Do you need a motion to table that?
No, we
think you
could
need
just,
a
we'll just
motion
bring
on
it back
this
to the
table.
full
We're
board.
not taking it
Yeah,
back.
there's no action. All right, item P, Daphne.
Yeah. These next two items are the annual funding agreements that we have with the county. The first one is for the specified countywide behavioral health and intellectual disability services to be provided to Tarrant County residents through the auspices of MHMR. Sorry, that's the second one. Yeah. The first one is for behavioral health and intellectual disability services for inmates at Tarrant County Jail and rehab alternatives for probationers and parolees, as well as public health services for Tarrant County residents. This is budgeted, and this year's spend, or the fiscal year 25 spend, the requested is $21,366,456. And the second one that I started to talk about is for the behavioral health and intellectual disability services to be provided to Tarrant County residents through the auspices of MHMR of Tarrant County. And the fiscal year 25 spend that is budgeted is for $1,594,650. Those are, again, both annual funding agreements. Those the specific services agreements that those funds track are between the county and those respective agencies. So, diplomatically, I will ask that you not do that for this year. We did budget it. So I think that there's opportunity to look at what's included. So for what I will say is for those services that are kind of part of that jail care, to the extent that those are healthcare services, those would be required expenditures for the hospital district in providing services to needy and indigent residents of the county. There's probably an opportunity to look at these funding agreements to see if there are other services that really aren't part of our required kind of requirement to provide those services for needy and indigent residents.
I'm not against the service.
Sure.
I'm against everything. without having any performance metrics whatsoever, any quality reports whatsoever, any discretion whatsoever over what happens to them.
I understood your underlying question.
I think what we've got to clean up is that we are responsible for the jail care. That would include the mental health care there. And so they should be contracted. We should either decide we're going to do it or they're contracting with us for that service. Right now, they contract with the county.
Yeah.
And that it does include other services outside of that, so I think we would probably have more time next year to look at those and see which ones that we want to have more conversation
Responsible
around.
for it or we're not. I mean, so.
I mean, does this money also go through to the diversion center that's not functional?
No, but there are, public health services and other services that are included.
Could we get it separated? I mean, and is this an increase from last year? I know that we do stuff every year. It bothers me that this is just like, give us this, and we have no idea how you're using it, and there is nothing there that says the outcome of that. Now, when you talk about concern, I'm concerned about that one. That is one that somehow we need to say, listen, you can give us this for these dollars. I mean, all we're asking is for you to tell us what you're using, set up some type of measurements on it.
Sure, and we do get to see the services agreements that the county has for these services with these other entities. So again, happy to bring those forward so we can talk about and parse through what those discrete services are and which ones we feel like we need to have additional.
Well, let me ask another question. If we're given the dollars, and so this is supposed to be for a service that I don't know what it is, and they end up not spending it, does it come back to us?
We do. There is a reimbursement mechanism under the first agreement that is for $21 million. That it does talk about kind of the true up around some of the funds that aren't spent for those discrete services that are listed out. For that second agreement, I don't know that it has that same language in the agreement.
Are they allowed to move dollars from one bucket to another bucket? And how would we know?
Increase in salary or something like that?
We
I don't know.
The honest answer is we wouldn't know.
Well, I just think that we can ask. We can ask for these to be defined, and something says this is what those dollars are for, and just like anybody else, if you're changing it, we should know about it.
Yeah.
So Dorothy, I guess the question is, so let's say I do know it, I'm not the one that's holding them accountable for how they
You're right.
spend it. And so, I mean, they can basically come in and say, this is how we're going to spend the money. I don't know, because they don't report into JPS, how it is we hold them accountable to what you're asking, whether it's metrics or whether it's,
So how can we get that? Maybe that's the question.
It's a
Because we
larger-
spend a lot of money with other agencies, and it is just not like a blank check. And there is something in the contract that could say something. Or I guess that says we don't have a contract then.
Right. You all have definitely brought some of these questions forward before. I will tell you that in the agreement that is for the services at the jail, they did embed some metrics into their underlying contract. To Dr. Duncan's point, one way that we had talked about being able to have more direct insight into the services that are actually provided there is for us to contract directly. But there's a bunch of additional services that aren't accounted for.
So is it feasible for us to start saying now, MHMR is getting the dollars from us, we contract with them? And not give it to the county, we contract.
That's what we were talking through to see if that could happen.
It's a larger policy discussion that
Well, it's a
will
part
not
of
be
the
solved
policy
today.
discussion. Well, I'm just saying, it's in discussion, but we've been discussing this for a long time. So is that a part of the recommendation that is where we want to go? Or do you think it's easier for you to do it one-on-one with them and the board not have any recommendation for it?
I think we have to do some internal analysis as to what that would mean. We'd have to better understand what are those services that MHMR provides that are separate from what we could provide. I think there's probably some crossover with that. And then what do they do that's clearly outside of our kind of core competencies? So there is some of that untangling that we would have to do. And then I think we'd have to sit down and look at kind of what those costs are.
Let me.
I think it's a whole different question is whether we want, whether I really want the jail or
do we
not
want to do
really,
it?
to be honest with you.
Yeah, that's the
Yeah.
This is county funded, obviously, right? And it's coming
But
through
it's
our
coming out
budget.
of our budget.
So, subject to the reduction in the tax rate that we've all put up with and talked about for the last 3 hours or so, was their budget reduced proportionally by that as well? Was this amount adjusted for that? In other words, are they feeling the same heat that we are feeling as a network?
No.
Okay, and again, similar to the way the county may have reduced our tax budget to give us a chunk of dollars to work with, do we have the same opportunity to reduce this budget by the same amount to reflect the reduction in ad valorem taxes that we got from the county?
Yeah, I think one of the challenges is what you all talked through earlier is that, these dollars were already included in our budget before that subsequent cut. So that discussion couldn't happen.
But with the notable exception that nobody at JPS or within the JPS finance staff had any say in the creation of these numbers, nor any line of sight.
Well, we
to those.
do talk to them about what they're planning to put into their budget for these services, and then that carries over into ours.
So when we now come and say we've got an increased jail cost, that's also MHMR has to up their care over there too. So the question is, I don't want to compromise jail costs because of a decision that was made by the county.
Well, and
so-
clearly anything we cut in this is going to wind up in our PEC, so.
Exactly. Yeah, so for those reasons,
And that's kind of
I don't
why the
know where
money
the
falls in
punishment
limbo
actually
anyway.
lays
Yeah.
at that point, yeah.
And that is the bulk of it. That's not all that's included, but that is the
The
bulk
bulk
of
is
this cost.
jail care.
Yeah.
I just think we need to start sometime of laying out what we would like to occur on accountability for dollars.
Yeah, I think it's a bigger discussion around what we do with jail care, I'll just be honest.
So Daphne, of this 21 million and the 1.5 million, how much of that, are we funding the entire program for jail care? Are the county putting any other funding into this?
For jail care.
For the
no.
stipulations here for,
Yeah, this is all.
this is all us. It's always been us.
Because they don't get any money from
Well,
anybody for
I think
jail
we look
care.
at it as
Doesn't come out of
JPS money, and the
statutes.
county looks at it, JPS money as county money.
Well, I mean, but also the sheriff's got a budget too. I'm all like, jail's got a
Doesn't
budget.
get this.
Okay.
He would love to have all of this.
I'm all like,
Daphne, your summary here says for the 21 million, as well as public health services for Tarrant County residents, so it's not all jail.
Correct.
What are those services, that phrase, as well as, what's included in that?
So there are some specific line items that relate to public health. I think we did include that exhibit or the entire contract in there, but it's not, I don't have the detailed line item, but there's some particular public health services that are included in the contract as well.
Public health is mostly FTE, I think, aren't there? I think theirs is mostly an FTE.
I think it's mostly, yeah.
Yeah, it's an FTE. Their programs are usually grant funded, and we have funded the FTE for some of, and it's not all the public health that we're funding.
No, we don't fund all of MHMR or public health.
MHR as other funding,
They have other funding, yeah.
besides this, okay.
We do most of their jail care. Some of that is transitions out of the jail. And that's what they're really good at, getting them connected back into the community to keep them from ending back up in the jail. So that's a lot of that transitions of care.
This comes up every 10 years. And we've all.
Every year.
I think the issue is with continued downward pressure on the tax rate, then the concern about our fiduciary responsibility over taxpayers' dollars that we have no say over is legitimate. And so from our perspective on the board, it's always been not a matter of should the services be offered, is they should be offered under the same circumstances that JPS involves those services, because that means that there's metrics, there's performance standards, there's accountability, there's a board that has to be answered to. And that's just never happened with this. So if I'm a taxpayer in Tarrant County, I'm like, well, why, if I'm putting my tax dollars into JPS, why are my tax dollars going to something JPS has no control of whatsoever? It's a legitimate question.
Absolutely.
It is.
You guys are going to oversee them. I mean, I'm not overseeing.
Are they looking at
Yeah.
potential or contracting for jail care? Is that
I think it's a,
I don't think anything's off the table.
yeah, I don't know that anything's on the table. I mean,
There's been so many vendors,
Yeah.
so many people approach the county about contracting this out, and it just never goes anywhere.
We'll start Telegram.
This may not be the best time.
Daphne,
it's a larger, yeah, it's a much larger discussion, and this thing has been a thorn in our side for a long time, and quite frankly, we really just need it to be a thorn in our side for this year. We've approved the budget, the court's approved the budget, we need to spend the money, and then,
That's it.
Not happy about it.
no, yeah.
So we can bring, right, we can bring the underlying contracts and then the funding arrangements so we can, so the board can have more insight into exactly what those buckets of dollars are and what those underlying contracts with the county look like. And then we can, get some direction on how to, we should move forward with that.
Okay.
Yeah, because the contract will allow them to give other funding to other nonprofit organizations and things like that doing work in this space. Is that correct? I mean, we just don't know. We don't know what they do with the funding period.
They have line items, I mean, on
Yeah,
here.
they're just line
They have line items, just like we do. They create a budget.
I have a,
part of their budget, do they ever say anything else about where they get revenue from beside us?
Are they going to go to the zero tax?
They do. They've got huge amount of grants that get state money. Is how we actually, I mean, they pay for beds over here at the LCA. So they pull down their funding from that. That really comes through them. So they're very assertive in getting funding where there's opportunity. I would say that MHMR is not lazy about trying to get funding.
I don't think my issue is MHMR.
Yeah.
are we providing these services in the jail for this $21 million interlocal agreement? Are our employees providing the behavioral care, or they're
This is for those,
They're-
MHMR and
We only
Public
do
health.
the non-mental health.
MHMR is providing most of the services
They do all the mental health services.
in the jail? So all this is ending up for MHMR, both of these agreements?
No,
One is
and public health.
the second one is MHMR though.
I'm talking about the $21 million agreement.
$21 million
Who's providing
HMR.
those services?
And then the smaller one is public health. The 1 million,
No, it's
The
opposite.
$21 million
It's the opposite.
is for behavioral health and intellectual disability services for inmates at the jail.
Yeah.
And rehab alternatives for probationers and parolees. And it does include some public health services.
Okay, so, and maybe just, I'll be hearing you guys, who's providing the $21 million in services, behavioral care services at the jail? We're writing the check. Who's doing the work?
MHMR.
MHMR is doing that.
These are funding agreements, so these are not services that JPS provides. It is a funding agreement back to the county for the services that they have contracted for from MHMR and public health.
Okay, and why are they splitting the two agreements instead of just one agreement?
One is not for jail services. It's for other services that are provided in the county by MHMR.
But even the first one has that clause that says, as well as public health services. So it's, for Tarrant County residents, the first one also is not purely jail services.
No.
That's right.
Public
First one
health
was
is in
public
there.
health.
And the reason for the disparity in the amounts of the contracts, I mean, $21 essentially limited to the jail or probationary status versus $1 million outside of the jail is because we are providing a lot of those services through PEC, behavioral health, and other community resources? I mean, the numbers seem whacked that.
Yeah, I don't think that these agreements contemplate, there's no layer in on our services. This is just relevant to agreements that the county has for these services with these other agencies.
So I guess then conceptually, why is the non-jail number so small? I mean, because $1 million for
Yeah, it's just different services that have to bring.
Right, but $1 million
the
for
underlying-
healthcare services in the community setting is going to last about 20 minutes. I mean.
They have monies from elsewhere. They're receiving the rest of
Okay.
them. I think it's, again, it's an FTE count.
Yeah, I think ours with public health.
With public
It's
health.
always been a function of 2 new employees or 1 new employee. That's where it's always been. There's never been, they're funding public health. The county's funding public health. But we're the ones that come to when it comes time for a new program, new employees. That's always been sort of an iterative feature of that understanding.
And I don't think they
Sure, I
asked
can
for
tell
any
you guys.
increase this year.
Unusual.
New person, not knowing.
So.
Motion to approve with prejudice.
So we'll take them separately.
I'll take them.
And obviously, Daphne, there's some things that
We ain't doing nothing.
we need to dig in further onto these.
Yeah, and we have, we don't have to get into it, but I did pull up the attachments, the exhibits.
We'll, Trent, I will take your motion to approve item P. And is there a second?
Second.
A second. Any further discussion? All in favor?
With disdain.
No, you didn't.
Any opposed? Got one opposition, DT. Thank you. And then I'll move to approve item Q, the MHMR Tarrant County agreement. Is there a second? Second. Any further discussion? And Daphne, you'll bring some more information for both of these, and we'll see if we can try to clarify this by this time next year.
Good luck.
Yeah.
Yeah.
No, I don't.
But it's not our, did you?
Right.
Go ahead and get that last
Yeah.
one.
I'm good, I just can't
Get a
correct this
motion.
one.
Any-
I'm telling you, I can't.
Any further discussion? All in favor? Any opposed?
This one befuddles.
I've got DT in opposed.
Always has been that way.
Thank you, the motion passes. Okay. All right, we've got, there's no consent agenda. We've got just a brief item in executive session, and we will take care of that now. 5-minute break for everybody. Thank you.
I can't leave at 30.
Thank you.
I don't think that it. We're adjourned.
We're adjourned. Thanks, Trent. Bye.